Good morning, everyone. Welcome back. I have always thought of this event as something of a reunion because we get to connect with so many old friends and welcome new colleagues and acquaintances. And this year it especially feels like a reunion because it's our first in-person event since 2019. My name is Cheryl DeMars. I'm the president and CEO of the Alliance, and it's my privilege to welcome you all today. Let me tell you what's in store. Okay, here's what's in store. This morning, first, you'll be hearing from Chris Whaley about the latest results, hot off the presses, of the RAND Hospital Price Transparency Study, which is really shining a light on healthcare prices across the country. Chris will be followed by Gloria Sachdev, who will talk about how employers and lawmakers in Indiana, where the RAND study was born, are using this information to change policy and the market. And after the break, we will then hear about some new provisions in the Consolidated Appropriations Act, which really raised the bar on employer fiduciary duty. All of this fits together, and you'll see how so as we go through the morning. Those of you who are here in the room are then invited to join us for lunch. We'll be having lunch right in here, so we hope you'll stick around for continuing the conversation and networking. Those of you joining us by webinar, apologies for the delay. We were working to get things set up for you, but welcome. We're glad that you were able to tune in. You are on mute, but we want to hear from you. So please, if you have questions or comments, add those to the chat feature, and we will feed those into the room at the end of each presentation. You can access the handouts that are being distributed in the room here through the handouts section of the webinar. And if you have any technical issues, please put that in the chat as well, and our tech support team will help you. Those of you who are here in person, you're not muted, and we can't mute you, and we don't want to. You will see that there are microphones positioned here in the middle of the room. Please feel free to go up and use those to ask questions of the speakers at the end of their presentations. We are really interested in your feedback and your thoughts. The handouts are all at your tables, and so you're all set. Just so you know, everyone, the handouts and the presentations will be available after the session next week on the events page of our website, and we'll send out an email to notify you that those are there. And speaking of in-person attendees and in-person attendance, I want to just take a moment to welcome Senator Mary Felskowski. Senator, would you please stand? Senator Felskowski is from the 12th District here in Wisconsin, and Senator Felskowski has proven to be a real friend to business and consumers who are working on the agenda of making healthcare more affordable through free market, common sense approaches. And Senator, we're delighted to have you here today, and we thank you so much for your support on these important topics. And I also want to do a shout out to the other people that are here in the room or joining us by webinar who are working to support the state legislature. We know how important it is to have objective, reliable information upon which to base public policy, and that is one of the reasons why employers across the country are supporting the RAND study, because it gives us that type of information. I also want to thank our sponsors, National Cooperative RX and Delta Dental, who are sponsoring us at the platinum level today. And now, it's my pleasure to introduce Chris Whaley. Chris is a policy researcher at the RAND Corporation and professor at the Pardee RAND Graduate School. Probably that's pronounced Pardee, right, Chris? Instead of Pardee, but maybe both are true. His research focuses on healthcare price transparency and market structure, and Chris's work has been published in a variety of clinical, health policy, and economics journals, including Health Affairs, JAMA, the New England Journal of Medicine, and his work has also been covered by the New York Times, the Wall Street Journal, Forbes, and CNN. He's presented his work to both state and federal policymakers, including the Congressional Budget Office. Chris has a BA in economics from the University of Chicago and a PhD in health economics from the University of California, Berkeley. And Chris was on the ground floor of the work that you'll be hearing about this morning. I would say, Chris, that this is the work that you and your colleagues at RAND are doing is quite literally changing the conversation in healthcare today. And it's making a difference in markets, for employers, and also in policy. And so we're anxious to hear about the latest results of the study that you've done. Please join me in welcoming Chris.
Thank you for having me, and really excited to talk about the latest round of our hospital price transparency work, where we've been able to get data from a large set of employers and look at what prices are for hospital care for employers from across the country. So I'm just some quick housekeeping work. So the study was funded by the Robert Wood Johnson Foundation, Arnold Ventures, and also many participating self-funded employers who decided they wanted to know information on prices for themselves. This study was conceptualized and is kind of the brainchild of Gloria and the Employers Forum of Indiana. And so you hear about kind of where EFI has been able to take this work over the last couple of years. I'm here talking to you today, but this study is actually the result of a broader group effort and many people at RAND who have worked on this project. So just why are we all here today, and why do we care about this topic? The employers in the United States really play a critical role in essentially financing the U.S. healthcare system. In the United States, employers provide health insurance for about half of the country, about 160 million people, and collectively employers spend about $1.2 trillion on healthcare, with the largest chunk of the pie, just under $500 billion, going towards hospital care. And so employers are critical in how we think about financing and providing resources for the healthcare system and for the provider delivery system. And so this is a huge and very important market. It's also a market that has faced lots of challenges, especially in the last several years. And in particular, if we look at where not just the money is going, but actually where it's coming from, it reveals some troubling trends. And so if we just look at data from the Kaiser Family Foundation at just where employer paychecks have gone over the last decade, we can see that the amount that workers pay in deductible payments, and so this is taken out of your health insurance or you pay to the provider before health care even kicks in, has increased by about 160%. Family premiums, which are predominantly paid for by employers but also come out of worker paychecks, have increased by over 50%. I think now it costs over $22,000 on average for an employer to provide health insurance for a family. If you're a lower income worker, that's money that in many cases is half of your salary and in some cases more. Inflation has increased by about 25%, and that doesn't even count for the last couple quarters. And worker earnings have increased by only 20%, and so below inflation. And so I think there's a growing concern, shared by many, myself included, that the rise of healthcare costs is essentially leading us to take money out of worker paychecks and pay workers instead of take-home dollars in healthcare dollars. And so that's something that we need, when we have these conversations, need to be aware of where the money is coming from. The second issue, which I think is becoming more and more important in the last couple of years, is just thinking about the employer's role as a fiduciary in providing health care for their workers. Many self-funded employers provide health insurance to the worker as a form of benefit, and as I mentioned earlier, are essentially taking money out of a worker's paycheck and providing health care with that money. And in doing so, the employer has a legal and moral obligation to make sure that they're doing that wisely. And in fact, if you go to the Department of Labor website, you can actually see that there is a clearly defined definition of what an employer has to do. And employers, when they're providing health insurance, have to act as solely in the interests of their plan participants, which is their workers and their families, and with the exclusive purpose of providing benefits for them. And so just the exact same way that if my employer were to take my retirement plan and say put it all in Bitcoin, if an employer is taking my money for my health insurance and negotiating a contract that's 600% of Medicare, that's the exact same money that's coming out of my pocket. And so if we think about this, very clearly defined definition of what the employer has to do and the employer's responsibility, how can the employer fulfill this obligation if they don't know prices? So if you or anyone in this room were to give me money and ask me to go purchase something for you, and I were to do that, you'd probably first ask me how much that cost, and if I said, I don't know, you'd probably say, well, that's not being a good fiduciary with my money. Healthcare is exactly the same. And so if we think about kind of the range in prices, we know that there are many cases where prices are just all over the map. And so there have been some recent price transparency regulations that have required hospitals to post prices. And if we kind of unpeel the onion a little bit and look at just the range in prices for many healthcare services, we could see that for this one particular hospital system, knee replacement, rather hip replacement prices range from about $85,000 for commercial insurers to about $14,000 for Medicare and about $30,000 in the middle for other insurers. And so as employers are navigating both this responsibility and just the rise of healthcare costs, this is the landscape that they're facing and just the wide range in prices. And so as we're thinking of kind of this market together and the employer's role as a healthcare purchasers, it's important to understand why we did this study. And so as I'm going to talk about in a couple of minutes, we were able to get lots of data from across the country and just look at the range in hospital prices across different services. And as we're doing this study, I think it's important to keep in mind that we as researchers don't actually know what the right price is for healthcare. We're not the ones that know your workers, your families, and the markets in which you operate. But we also know that you as employers can't make these decisions and can't decide whether you're paying too much or too little for healthcare if you don't have access to price information. And so what we wanted to do, and the tool that Gloria is going to discuss in a couple minutes, is actually give employers information on the prices that are being negotiated on their behalf and through the networks of TPAs, brokers, and consultants that you rely on to essentially establish your healthcare benefits, and then give you as employers this information and allow you to make your own decisions on whether or not the prices that you're paying actually align with the value that you're getting for healthcare. It's important to recognize just the context that we're in. The COVID pandemic has placed an enormous amount of financial burden and pressures on the healthcare delivery system. Many hospitals, provider groups, and physicians are incredibly stressed right now, both kind of emotionally, well-being-wise, and financially. But at the same time, these same financial pressures have impacted many employers as well. And so I'm sure that there are many employers who over the last couple of years have dealt with some of the most challenging issues that they faced. Everyone, I think, recognizes that hospitals and healthcare providers are critical members of communities, and we want to make sure that they stay there and they're able to stay in business and fully operate. But at the same time, healthcare expenses are, for many employers, one of their largest, in many cases, their second largest line item expense. And so I think in this challenging environment, this is actually the time where we need to not run away from information about prices, but actually have more information and use information to make decisions that in some cases may be very challenging. And so, as I mentioned earlier, this is the kind of the fourth wave of the study that we've been able to do. This study really just started in the state of Indiana, where EFI and other employers in Indiana essentially had a question of how much are we paying for healthcare? We want to be responsible fiduciaries, but we have very hard time getting access to information about prices that are out there negotiated on our behalf. And so we were able to get data from a set of Indiana employers, look at a kind of very high level facility fees, and so this is the amount that goes to the hospital service for this handful of employers, and just document across the state of Indiana, this is the range in prices. For this, we were able to just look at how everything compares to Medicare and just kind of produce a kind of Indiana-specific report. After that, word, if you will get out, or got out rather, and Gloria was able to take this on the road, if you will. And so we got a lot of information or a lot of participation from other employers from other states, and in RAND 2.0, we're actually able to include data from 25 different states, and so about half the country. We were able to get additional employers to participate, as well as 2 state all-payer claims databases. I'm going to touch on APCDs in a little bit, but essentially the way you can think of an APCD is instead of going employer by employer, this is actually a huge chunk of data from a large population in the state, and so really just increases the sample size and the ability to look at a very granular level hospital prices in that state. We're also able to add inpatient and outpatient fees and kind of separate where the money is going for hospitals, and then also look at standardized prices, and so I'm going to talk about what this means in a second, so we have 2 different price metrics. Then about 18 months ago, we released RAND 3.0, where we were able to look at 49 states. We've excluded Maryland because Maryland has a very unique all-payer rate setting model. We were also able to add 4 additional APCDs and add professional fees and look at prices for a few large categories. And then what I'm going to talk about today, we've been able to expand and essentially, I think, triple the data size of our study. A big chunk of that has come through adding additional state all-payer claims databases. And then also we've been able to look at prices not just for hospital services, but for ambulatory surgical centers. And so this is a facility that provides lots of outpatient care and is a competitor in many cases with hospital outpatient departments. And then we're also able to look at prices for COVID services and just look at how prices ranged for COVID. And so just kind of the general process for how we've been able to do the study. We kind of start by collecting data, and so most of the data comes from individual employers. We've been able to get data from a few health plans, and then also from state all-payer claims databases. With this huge collection of data, we essentially aggregate and standardize across these different data contributors and make sure everything looks right, then map providers and facilities and try to look at kind of map the kind of organizational structure of the healthcare system in the U.S. And then we, with this data, look at prices in 2 different ways. And so I'm going to clearly define these in a slide or 2. But we have a price that's relative to Medicare, and so this is the percent of Medicare benchmark that we talk about the most. Then we also have a standardized price, which is essentially just kind of an average price adjusting for differences in patient complications. Then we also have the what we call a public report, and so this is the kind of RAND study that's online, and you can go through and kind of read our methodology and our high-level findings. And then we also have an Excel file where you can actually look at individual prices for services. We then have been able to now take this data and actually put it in an online dashboard, which Gloria is going to present after me. And then we also, for many employers, you might say, look, this is great to see what prices look across the country, but as a fiduciary, I want to know what prices look like for my individual population. And so we've been essentially able to subset on a given employer and say, for your specific population, this is how prices look like, and this is also how prices look like across other employers across the country. And so when we compare prices across hospitals, this is something that is going to be a bit of a challenge. And so every single hospital is different. They do different mixes of services. They have different patient types. They have different payer structures, et cetera. And so if we were just to, say, compare prices between 2 hospitals, that would be pretty misleading. So for example, some hospitals may do lots of MRIs. Some hospitals may do lots of heart transplants. If we were just to compare the 2, that's going to be clearly a wrong comparison. And so what we're going to do is we're going to rely on the Medicare system and a lot of the details that Medicare has developed over the last several decades to make more of an apples-to-apples comparison that allows us to compare different hospitals. And as with many things, there's more than one way to do things. And so we call this, we're going to make an apple pie but have 2 different recipes. And so the first approach that we use is percent of Medicare. And this is the one that we refer to the most and use the most commonly. And essentially what we're going to do here is we're going to look at what employers are paying every single hospital and look at every single claim that comes in our database, and then reprice that relative to what Medicare would have paid. So essentially what we're going to be asking is the question of how much would Medicare have paid for this exact same service at this exact same hospital? What we like about this metric is it's easy to compare across hospitals and across states. And so if we see that one hospital is, say, 400% of Medicare, one hospital is 200% of Medicare, that gives you a pretty good sense of which hospital is more expensive. Another advantage of the percent of Medicare number is that Medicare actually adjusts for a lot of kind of things that go into producing care. And so it's probably more expensive for a hospital to hire a physician in New York City than in Iowa. And so Medicare makes that type of adjustment and is able to adjust for, say, cost of living, the share of patients that are low income or uninsured, and the complexity of the patient's or the hospital patient population. Our second approach is what we call standardized prices. And so if you're an employer, maybe it's great that Medicare does all these adjustments for, say, cost of living, the complexity of the hospital, whether or not the hospital is a teaching hospital or not. But maybe you as an employer just want to know what's the dollar number, and you don't really necessarily care about these other inputs that the Medicare puts in. So that's the purpose of this standardized price measure. And so the way to kind of think about this is we're still going to use Medicare's payment system, but more as a way to compare across different procedures and patient populations. And so one way to think about this is that Medicare has decided that if you're providing a heart transplant to a patient, it costs 34.65 times more to provide that care in terms of the intensity of care, how long you have to have the operating room, the number of physicians and nurses that are required to do this, than just to treat a patient for chest pains. Medicare has done this for every single service that a hospital can do. And so we're essentially going to use all these different types of metrics and comparisons to adjust for differences in the cost of treating a patient. And so we're going to use these weights to essentially make an apples-to-apples comparison across hospitals and have a dollar amount that is essentially the average price, adjusting for these other factors. And the advantage of this for an employer is that you have an amount in dollars that you can compare across hospitals. And then if you don't want to, you don't have to necessarily worry about the other kind of inputs that go into a hospital's payment through Medicare. And so just one kind of final note on comparisons to Medicare. We're again, not saying that we know the right price for any service. And so we're using Medicare's price and Medicare's payment models as a chassis to compare prices across different hospitals in a way that allows us to make these comparisons across hospitals in a fair and transparent way. But we're not saying that employers need to pay Medicare rates or using Medicare prices as an endpoint. What we like about Medicare is that this is an empirically based and transparent approach. And so maybe there are other ways to compare prices across hospitals. They haven't been developed over several decades. They're not used by the largest payer of healthcare services in the world. And they haven't been designed with the same level of input from industry, including hospitals and physician groups, on how to set payment rates. The other advantage of Medicare rates is it's fully transparent. So you or I or anyone can go into the Medicare website right now and look at how much Medicare pays hospitals for the exact same service at any hospital across the country. And so by using these, we're essentially allowing employers to benchmark prices relative to Medicare and the largest payer in the world in what we think is a pretty fair and transparent way. So what did we find? So in our latest round of the study, we were able to include data from about 4,000 hospitals and 4,000 ambulatory surgical centers. That's the majority of hospitals and ASCs in the country. We, in this data set, found that there's a wide variation in prices across the country. In most states, except for one notable exception, facility fees are much higher than professional fees and really drive prices. We also found that prices for COVID care actually resemble pretty closely and mirror pretty closely prices for just general inpatient care. And then we also found that if you extend the results to not just hospitals, but look at differences in based on site of care payments, prices for ambulatory surgical centers are quite a bit lower than prices for hospital outpatient departments. And so our findings in more detail. So our top line finding just looks at relative prices for hospital services relative to Medicare for each state. And so what we found here is that across states, there's just a tremendous amount of variation in prices. So in some states like Hawaii, Arkansas, and Washington, prices relative to Medicare are below 175%. Some states like Florida, West Virginia, and South Carolina, prices are above 325%. And Wisconsin actually comes in at fourth at, I think, 307%. And so the thing that really, every time we do this and every time I see this is still just shocking to me, is that for literally $1 trillion industry across states, there's literally a 2x variation in prices for hospital care. And so in industries that are this large and this sizable, we don't typically see this type of variation, and so really suggests that there's something really unique and potentially that might need to be addressed about healthcare markets in the United States. We also might worry that, well, look, maybe these prices in, say, Florida, South Carolina, and West Virginia are needed for the healthcare market, but healthcare seems to work perfectly fine in Seattle. When we look at the prices for Illinois, we found that they're actually in the middle of the pack at 24th highest. And so these are two neighboring states with prices that are very different from each other. If we unpeel the onion a little bit and look at the two components that drive hospital prices, and so these are our facility fee payments and professional payments. The facility payment is the amount that goes to the hospital, and the professional payment is the amount that goes to the physicians and other healthcare providers that are doing the service. And so when you get a healthcare bill, you essentially have bills from both types of providers. And so what we did next is we looked at those two parts separately and looked at prices for just the facility component. So again, this is the amount that goes to the hospital. Here we actually found that Illinois, again, is exactly in the middle of the pack, and Wisconsin actually shifts down a little bit, and instead of 4th highest for the total price is actually 17th highest. And so maybe what this would suggest is that for the amount of the bill that goes to the hospitals, the story in Wisconsin may be a little bit more typical with the rest of the country. But again, if we look across states, we still see that in the bottom end to the top end, there's about a 2x variation in facility fee payments. In most states, facility fees account for about 80 to 85% of the hospital bill, but that's a little bit different in Wisconsin. And again, if we look at prices for just inpatient services, and so this is the facility fee that goes for an inpatient service, Illinois and Wisconsin, again, are pretty much in the middle of the pack for the rest of the country. And then if we do the exact same thing for outpatient facility fees, and so for outpatient services, this is, again, the amount that goes to the hospital, we actually find that, again, Wisconsin and Illinois are pretty close to the rest of the country, but actually Illinois is a little bit higher than Wisconsin. So for outpatient services, Wisconsin's actually kind of right, again, in the middle. Now, when we turn to professional fees, and so this is the amount that goes to the doctor or the healthcare providers that provide services, we actually find that Wisconsin is much higher, and so now about the second highest in the country. And so if you look at across the country, most facility fees most professional fees rather, are about 150% Medicare, and there's really not a ton of variation across different states. And so in most states, it's really the facility fees that drive prices in that state. But in Wisconsin and also Minnesota and Alaska, we find that it's really the professional fees that are outliers compared to the rest of the country and contribute to the higher prices relative to Medicare when we look at the total hospital bill. And so, it probably costs a lot to hire physicians in Alaska and get somebody to move to Alaska, and so maybe it makes sense that Alaska is an outlier. I'm not quite clear what the story for Minnesota or Wisconsin is and why those states have so much higher facility or professional fees rather relative to other states. And so in Wisconsin, for example, we find that professional fees are just under 400% of Medicare. And so relative to what Medicare would pay, professionals in Wisconsin are getting about 4x of that. Then we were also able to look across our study and look at the states that included an all-payer claims database. And so as I mentioned earlier, we were able to get APCD data from 11 states. And this really allows us to essentially get kind of a whole look at the APC or the population in that state rather than going employer by employer. And it really enables us to get a huge insight into that that state's population rather. One thing we did notice is that the 11 states that contributed in APCD, did tend to have lower prices, and so it's not quite clear whether this is, the APCD actually enables the state to think about payment policies differently and actually enables the state to actually design programs to address high prices and make sure that prices are low and to monitor prices. We do know that some states, so for example, New Hampshire and Colorado, do actually use their APC data pretty actively and are really kind of informed monitors of what's going on in their state and are actually using information to drive policy. Some states do have APCDs, but either have restrictions on sharing that data or we weren't able to get that data in our study. The other thing we looked at was just prices for COVID care, and so what we did here is we looked at what's the standardized price for an inpatient COVID stay. Again, this is standardized, so if somebody, say, has a 40-day stay in the ICU and somebody has, say, only a 2-day stay, we're adjusting for those differences, and so we're not kind of just comparing across average prices. And so what we found here is that just across states, and again, in this adjusted way, there's a pretty wide range in prices for COVID hospitalizations. So in some states, Mississippi and New Hampshire, for example, prices were around $10,000 for a COVID stay. Other states, New York and California, prices were above $40,000, and in California's case, closer to $50,000 per COVID stay. For Illinois and Wisconsin, we found that similar to the facility and inpatient side of things, they were actually pretty close to the middle, and Illinois is actually on the lower end of prices. And we then looked at COVID hospitalizations, not just in the dollar standardized amount that I presented earlier, but actually as a percent of Medicare. And so essentially what we're doing here is we're saying, what's the percent of Medicare for a hospital's COVID stay for inpatient services, which are highlighted in the pink? And how much would what's that hospital's relative price for all inpatient stays in 2020 for what that hospital does? And so what we found here is that there is some difference between the two and some gap, but in general there's a pretty strong correlation and pretty strong relationship between a hospital's just general prices for inpatient care and how much that hospital got for COVID care. That probably makes sense because hospitals, when they bill for COVID patients, are still billing under DRGs, still billing for ventilation, and still using the same billing infrastructure. And so maybe it's not surprising to see that COVID care actually tracks pretty closely prices for just kind of general inpatient care. I think another takeaway here is that while there have been lots of just overwhelming, in many cases, hospitals COVID patients, in general, especially for privately insured patients, this is care that is still reimbursed at relatively high relative to Medicare rates, and so this is not necessarily representing care that's totally uncompensated. An advantage of our study and our data is that we're actually able to name prices for specific providers. And so if you go to the Excel sheet that I mentioned earlier, probably much more easier through Sage, you can actually look at what are prices for individual hospital systems and how do they compare across the country. And so with this data, you can essentially say, for the hospital in my market, does this price align with the value that we're getting, and how does price compare to another hospital system? At the top of the list this year is again for, I guess, the second year in a row, John Muir Health, which is the hospital where I go to, and so that's in the Bay Area. We tend to have high prices for hospital care, but this is a hospital that is it's a good hospital, but next door are the University of California, San Francisco, Stanford Health, which are kind of world-renowned facilities, and they're actually lower priced than John Muir. And so if you go to either the RAND website or through Sage, you can actually look at prices for your individual market or maybe a hospital where you go to and make these type of comparisons. So one other perspective is that, well, look, high prices are maybe necessary, and actually, like many things in life, you pay for what you get. And so if you have a high price, then healthcare is one of the, if not the most important thing that we get and that we pay money for. And so maybe we're actually, should expect to pay high prices, and maybe that's actually not a bad thing. And so we took that to the data. and we're able to look at how a hospital's price compares relative to what their quality is. And so for quality, we use data constructed by Medicare through their star system. And so essentially just kind of like Yelp, we're able to get every hospital's stars, and so with 5 stars being the best, and 1 star indicating the lowest quality. And then we just bucketed hospitals into low price, so those that are below 150% Medicare, medium price, those between 150 and 250% Medicare, and higher price, so those above 250% Medicare. And what we found is that there's actually not this strong correlation between price and quality. There are many higher price hospitals that have 1 or 2 stars, and there are many lower price hospitals that have 5 or 4 stars. And actually, if we look at the bucket with the most 5 or 4 star ratings, it has actually the medium price hospitals and not the higher price hospitals. And so this kind of link between price and quality in healthcare, we didn't find any relationship to, and many other studies that have looked at this question have also not found a relationship. And so it's not the case that if we're paying high prices, that's necessarily reflected in the value or the quality of the hospital. The other 2 stories that we've heard a lot are that if you're a high-priced hospital, that's in some sense necessary because you are being underpaid by Medicare, Medicaid, uninsured patients, and uncompensated care patients, and so you just have to charge higher prices to make up for those underpayments from other payers. And so again, we took that story to the data, and what we were able to do is look at each hospital's price relative to Medicare, and so that's what's on the left on the vertical axis. And on the bottom, on the left-hand side, we were able to get data on the payer mix for every single hospital in the country, and essentially look at how much they're being paid, or how much of their population is either Medicare, Medicaid, uninsured, or charity care patients. So essentially everyone who's not a privately insured patient. And so if the kind of the cost shift story is true, then what we should see is the hospitals that have lots of Medicare and Medicaid patients should be the ones with higher prices. Hospitals with very few Medicare and Medicaid patients should be the ones with lower prices. So at least when I look at this chart on the left, it looks like a random scatter of dots. And if we do the kind of the statistical test, we find no relationship between the hospital's payer mix and their price. And so it's not the case that hospitals are charging more to offset for underpayments through Medicare and other public payers. And so maybe what does explain it? So the other potential story is that hospital market share could be driving things. And so we were able to use the same data and essentially look at what's the kind of hospital's market footprint in their area, and look at what's the relationship between price and market share. And there we actually did find that there is a pretty strong relationship between hospitals' market share and price. And so hospitals with more market share are able to charge higher prices. And I think another thing to note, if you look on the right-hand side, we also found that there are many hospitals that literally have 100% market share in their markets. And so, as I mentioned, the other thing we were able to do is look at prices for ambulatory surgical centers. And so these are, again, facility-adjacent providers that provide lots of outpatient care. And so what we did is we looked at prices for ASCs relative to Medicare, and so that's in the dark blue lines. But then in the light blue lines, we essentially said, well, look, Medicare actually pays ASCs a little bit differently than hospital outpatient departments and at a lower rate. And so what if we took a given ASC and said it was a hospital outpatient department and it essentially was paid under Medicare through that rate? And there what we find is that across the board, prices for ASCs have been relatively stable for the last 3 years. And if we look at through kind of the ASC lens, average about 160% of Medicare. But if they were priced at a hospital outpatient department, would actually average about 117% of Medicare. And so there's a pretty huge gap between prices for ASCs and ASC, or for ASCs and hospital outpatient departments, if you look relative to the slides earlier. And then if we look across states, we actually find that in Wisconsin, ASC prices are maybe a little bit higher than other states. In Illinois, prices are, again, about the middle of the pack. But relative to Medicare, around 200% in Wisconsin, and a little bit lower in Illinois, which, again, is much lower than the 400% Medicare or 300% Medicare that I presented earlier for Wisconsin. And then the other ASC point that we made is we're able to just look at kind of the 5 most common procedures that are done on an outpatient basis and look at the price for those same services if they were done in an ASC in commercial payments, and then also look at Medicare payments and compare prices between ASCs and hospital outpatient departments. And so what we find on the commercial price is that the exact same services done in an ASC average about $2,400. The same service done in a hospital outpatient department average about $6,300. And so on commercial payments, that's about a 2.6 price gap. If we look at the same payments in Medicare, there's actually about a 2.1x price gap. And so both in Medicare and commercial, the exact same set of services are paid for a lot more in hospitals than non-hospital settings, but the side of care payment gap is actually larger in commercial plans than in Medicare. So those are our kind of top line results. And so then wanted to just kind of touch on how employers have actually used this type of information. And so the way I kind of think about the use cases of this type of data is that there's really, at least from what I've seen, a continuum. And so some employers are excited to really just kind of have information about prices and kind of think about what's next. Some employers have actually used this data to go out and actually benchmark prices. And then some have actually thought about changing hospital networks and essentially putting more pressure on payers and prices that are negotiated on their behalf. So at the first end of the spectrum, some employers are just kind of excited to have this information. I think a really good example of this actually comes from the Colorado Business Group on Health, where they're able to use our RAND 2.0 data and combine that with information on quality for Colorado hospitals that they've been able to collect and essentially produce kind of their own internal Colorado-specific report that really kind of designed kind of the range of price and quality for Colorado hospital, and then proposed a few policy options for both employers and the state of Colorado to make. This has been really interesting to see over the last couple of years because the state of Colorado tried to use this data to implement a public option and some of the findings from this report. And then actually a group of Colorado employers recently in the last year or so formed a collective to go out and jointly negotiate prices based on a lot of the findings from this report. The second way that employers, I think, have been really able to use this data is to say, look, we're as employers are paying a huge variation in prices relative to Medicare, and so we want to ask and place pressure on our plans to actually go out and set a price relative to Medicare and to cap that price. And so actually from Indiana, we were able to see some employers go out and say, look, we want for outpatient care a cap relative to Medicare because we've seen from our RAND 2.0 data that outpatient care just varies a lot relative to Medicare in Indiana. And so we want a benefit design that actually standardizes price relative to Medicare. And so I think this is a pretty easy thing for employers to do, and also makes just kind of the life of the employer as a purchaser hopefully much easier. And then I think the other spectrum that employers have been using this data is to actually go out and think more about the prices that are being negotiated on their behalf. One example that actually comes from our RAND 2.0 study, where instead of John Muir being the top, we actually identified a hospital in Fort Wayne, Indiana, Parkview Health, as the most expensive hospital in the country. This got a lot of attention. The New York Times and others splashed on their headlines. And so we saw this and thought, look, there's a lot of interest in the study. Employers in Fort Wayne saw this and essentially went back to their insurer, which in this case was Anthem, and said, look, why are you out there negotiating the most expensive prices for healthcare in the entire world? And we, as employers, are paying you for the privilege of doing that. And we now kind of know what's going on under the hood. And before, actually seeing this, had no idea what's going on. And so now that we actually have this information, we're essentially going to use it to audit you and to make sure that the prices that you're negotiating, again, on our behalf and for our workers, actually align with the value that we're getting. And so these employers essentially went back to their TPA, again, Anthem, and said, look, if you don't do a better job, we're going to think about a different TPA, or at least think about a way to get lower prices. And so this actually led to a pretty long and interesting contract renegotiation between Anthem and this Parkview Health system, which Gloria and I were actively involved with, and it's really fun to watch. And so this actually led to a new contract between this hospital system and Anthem, which is supposed to save the employers in this market quite a bit of money over the next couple years. And so I think this really gets back to one of the earlier points I made, that employers are fiduciaries for their workers and their families. And if they don't have information on the prices that are being negotiated on their behalf, and really on behalf of their workers, then they can't be responsible fiduciaries. With this type of information, this allowed the Fort Wayne employers to act as a responsible fiduciary, and in areas where the prices that were being negotiated on their behalf didn't align with the value that they were getting, they were actually to act as responsible purchasers and make sure that they were getting lower prices. And so just to wrap up, rising healthcare costs are placing a tremendous amount of pressure on workers, especially lower income workers, and I think this is especially acute during the COVID pandemic. The glass half full view of the information that I presented today is that the wide variation in healthcare prices, and especially hospital prices, in some sense represents a savings opportunity where employers can look and see these are the hospitals and the providers that are delivering lots of value, and these are the ones that are delivering lower value, and think about ways of shifting patients to the hospitals that are getting lower value or getting higher value rather, and making sure that the prices align with the value that they're paying. Employers really need to demand transparency and demand access to the data that reflects the prices that they are paying, and so they need to have access to the claims data. And then they also need to make sure that it's not just enough to have the data, but they actually have to use it to inform their benefit design strategy and to inform it in their fiduciary responsibilities. And then I also want to note that in many cases, the employer, is in some sense limited in what they can do as an individual. And so employers might want to also think about policy options and making sure that markets are competitive and that they as purchasers can operate in a market that provides them opportunities to have access to lower price providers. So thank you for inviting me, and happy to answer questions in the next couple of minutes.
Thank you, Chris. That was great. I have to just ask the first question, and I'd invite others to come to the mic with theirs. But obviously the prices paid by Wisconsinites to physicians is stunning, and really shows us as an outlier. And I want to go deeper on that and ask you if you have theories about why that might be. And I also want to ask that of the audience. We have a lot of smart people in the room who may also have knowledge of our market or theories about why it is that we look the way we look. So we'll start with you, though. Do you have thoughts about that?
Yeah, so the market share study or slide that I presented earlier was specific to hospital market share. But we know that market share also exists in other healthcare sectors, including physician groups. And so Wisconsin has a concentrated physician market, and so that probably contributes to the high professional fees that we see in Wisconsin. I think another note too is that in areas where professional fees are high. That's maybe an area where, as we're thinking of physicians being, say, bought out by, say, private equity firms or hospital systems, a lot of that just really kind of contributes to just the kind of churn that we see in healthcare going on right now in physician markets.
Thanks, Chris. Other thoughts about why Wisconsin might look the way that it looks in terms of being an outlier on the prices paid to physicians? I'll come to you.
Well, I'll respond. And hi guys. I'm gonna actually use what my colleague Deb Conferman said to me a couple weeks ago when I asked that question. In fact, do you wanna give the answer? Or one of the answers anyway? I'm putting people on the spot, I don't mind. Excuse me. Taking over the show. Ms. Deb Conferman, VP of Network Development for the Alliance.
Melina, you are a rascal. So one of my comments from being in the greater Wisconsin market in healthcare for, I'm going to give my age away, but 30 years, one of the things that I think is interesting about the Wisconsin market specifically is going back to what Christopher said. I believe in Wisconsin we have large healthcare hospital systems, and we have very few independent practitioners left. I think that in and of itself raises our professional fees greatly in Wisconsin.
I'm Ross Biela. My company's Aletheus. We do data analytics and have clients across the country. One thing, the reason we started this is because the healthcare costs in Wisconsin were just out of control. And Chris, thank you so much for your presentation. It's right on, spot on. Because we have clients in other states, particularly nearby in Minnesota and Illinois, it's not uncommon to see, 200 or 300% of the charges or allowed amounts to physicians in Wisconsin. What we can't find is an independent cardiologist. The systems did a very good job very early buying up all the independents, which was part of it. I think the insurance companies in particular were hand in hand when you have a large, fully insured population, where when you have an insurance company with their only ability to increase their profits by having the prices go up, they had no incentive to push back, and so therefore they let it roll in Wisconsin. And when you have United Healthcare and Anthem with a very significant market share in the state that are not controlling that, as you saw in Indiana, it manifests in exactly what you see here, with Wisconsin being at the top third of the costs in any manner in which you look at it.
Thank you so much. We do have some questions from the audience.
One more, please.
Okay.
Hi, I'm Dr. Wendy Malaska. I'm a family practice physician with a direct primary care practice. I was an employed physician, and one of the things that I would say in terms of physicians, as we talk about what we're actually being reimbursed, what that number that we actually see in our pockets is not what is reflected here. Most of the doctors, especially in primary care, actually had decreases in salaries during the pandemic because the hospital said that they were losing money, or the HMOs or whatever it was. So most of my colleagues who are in employed practices actually had their salaries decreased over the last couple of years.
Thank you, Dr. Malaska. More questions from virtual?
Yes. So the first question coming in is, has RAND considered looking at price comparisons to other countries that would be comparable to the United States?
That's a really good question. We have not done that in our study, but other studies that have done that using different types of data have found, if you compare even the lowest price, or if you even compare Medicare rates to other countries, the U.S. is an outlier. And so just looking at, say, Medicare rates to the other kind of developed countries, we'd get kind of almost the exact same chart where just Medicare rates would be at the top of the list relative to other countries.
Great, thank you. And are you able to make any observations on quality as it relates to Medicare? For example, does Wisconsin have less readmissions or better outcomes?
So we didn't necessarily look at Wisconsin-specific quality, but if we just look at, in general, quality ratings across different hospitals in the relationship to price, we don't find any relationship. And just to kind of unpack the quality metrics that we used earlier, so this is the CMS star rating, and so it's kind of it is probably the most robust measure of quality out there. And it includes things like readmission rates, patient satisfaction, and other clinical and satisfaction-based measures.
Thank you. And do you have any response to health systems and hospitals associations claiming this information is inaccurate?
So, yeah, yes. And so I would say that kind of, the boots on the ground response is that we have access to a huge collection of claims data. This is not data that kind of is maybe prices. This is literally the receipts from hospitals, and this is the bill that employers and workers and insurers end up paying. And so in that sense, that this is the price, and whether it's, you think it's the price that's not right or right, it is the price that somebody paid and somebody was charged. And so, in that sense, that is the price, and so that's why we use claims data to these studies. The bigger picture response is that This is a huge industry. It is a very, if not the most important industry in the United States. There is no transparency on prices that exist relative to other industries. And so if our prices are wrong, or if other areas need to have more information on prices, then the people charging those prices should actually post those prices. And from our perspective, if we didn't have to do all this work to actually go through and look through these huge troves of claims data to actually look at prices, and prices were already out there like everywhere else in the economy, then at least for my inglorious workload, that would be fantastic.
Yeah, I'm just coming at this from the fiduciary lens, which has been sharpened lately, obviously. I chair the 401k committee in my company. We have about $70 million of our employees' retirement money that we have to manage, and there have been a lot of lawsuits across the country over management fees. For a couple of tenths of a percent will cause a suit against the employer's health plan, and they're usually successful. So I'm sitting there looking at this and saying, hey, I know we're at 400% in Wisconsin. If we now have the same fiduciary responsibility for managing the employees' health care dollars, are not we all at a huge liability in terms of our fiduciary responsibilities? If we're at 400%, and over on the 401k side, there's suits if we're off by a couple of points on the management fee, a couple tenths of a points. It just looks to me like we better get a lot more serious about managing this god-awful mess on the pricing side of healthcare. And don't we have a responsibility to rationalize it? I'm John Terinas. I have a company called Serigraph. We have about 500 employees.
So certainly, I think the employer has a moral and fiduciary responsibility to manage healthcare costs and to ensure that if they're paying 400% Medicare, that actually aligns with the value. They're getting 400% of the value. There are many, I think, kind of bubbling people who have thought about this exact question, and is this also a liability issue to an employer? So that's maybe coming, but I'm not sure exactly how it will fold out.
For a niche, have any employers like myself been sued because their health plans are undermanaged in terms of controlling costs?
Not yet, but my uninformed opinion would be that soon.
I'm a young, ambitious lawyer, and I'm looking for a niche. I might want to sue a couple of health plans.
Thank you. From a legislative standpoint, when we start looking at healthcare transparency and we start to bring in all the groups and how do we get to the base of that, we run into proprietary information where nobody's going to give us information, or this network doesn't want to give up this and this network doesn't give this. Is it fair to say we could use an uninsured cash price? Or how do we set that benchmark? Because I've got the hospital systems pushing back and saying, sure, the outpatient surgical can do that, but they'll take the gallbladder patient that's 100% healthy, but they won't take the gallbladder patient that may have diabetes or has comorbidities. They want those done in the hospital because of something happening while that person is on the table. So how, as a legislative body, do we get at true transparency? What is our benchmark?
Yeah, so I think the best way you can do this is to push for all-payer claims database where you actually can see this information, and you can know actually negotiated prices by payer and say, for a given hospital, this is the negotiated price. It's not the cash price or the bill master or your charge master price, which in many cases is just out of the sky and doesn't matter. So you actually need to have the negotiated price. And then with a APCD or other data sets, you can say, look, is it actually the case that sicker gallbladder patients go to the hospital instead of the ASC or the outpatient facility, and actually answer those questions yourself. In general, we don't see that this type of risk selection actually happens. And if anything, this difference in prices is almost pure margin for the hospitals.
Thank you.
One thing that comes to mind on the legislative front, Representative, is, a few companies are now using reference-based pricing, where they peg their contracts or what they'll pay to the Medicare pricing, which is obviously, you guys decided that's the most valid database that there is in pricing. And then, of course, what happens is you bill at 150% of Medicare, 200% of Medicare, and the provider comes back against the employee for the balance. And so the legislature could prevent that balance billing.
There's been conversations around that, I will say.
Well, and I guess there's just one other note too, is that in many states, and I'm sure Wisconsin, the state employee plan is a large employer and can actually drive many of these innovations for themselves. So for example, we think of the two largest reference-based pricing programs in the country. They've been both in the state of California through their CalPERS plan and also through the state of Montana and their employee plan. And so I think that the state and municipalities actually have a lot of room to be innovators in this space.
They really do. And in Wisconsin, we're very unique. We have the Government Insurance Board who sets the plans, and the legislature just pays for it. Twice, as a legislator, I've tried to get legislative oversight on the Government Insurance Board, and it's been vetoed. So please put pressure on the next governor to allow legislative oversight, because right now we have the users of the plan designing the plan. And it's a Cadillac plan that is so far away from reality, it's unreal.
I remember talking to Dave Newby when I headed Competitive Wisconsin, when it was a combination of labor and management trying to solve mutual problems. I said, Dave, there's no benefit to anybody in having really, really high healthcare prices, including your members. And so why don't you, look at it from a quality lens? We all know that the better the quality, the lower the prices. It's just pretty simple. I'm in manufacturing, and that's how it works in manufacturing. If you got your defects out of your system, you got the waste out of your system, you can lower your costs, and therefore you can lower your prices. So I tell Dave, let's get together and put together, using ETF, the Employee Trust Fund, as a leader on interjecting rational pricing into healthcare. I couldn't get him to move.
Hi, thank you for your presentation. Jim Beyer, the Fall River Group. My question is are there any conditions that exist in the states that have costs that are closer to Medicare that we might be able to replicate in Wisconsin?
So in many cases, these are states that just have more competitive healthcare systems, and so there aren't the same number of dominated healthcare plans that really control the market. I think the good example of that is that we find that the state of California is actually roughly in the middle for healthcare prices, but if you were to draw a line across the middle of California and split it between northern and southern California, northern California would be, if I went to the top 20 list where most of those are, and it would be the most expensive state in the country. Southern California, which is a very competitive hospital market, is actually on the lower end. And so exact same states, just different competitive environments, and prices in Northern California are about twice what they are in Southern California.
Thank you. Chris, you mentioned all payer claims databases, or APCDs, that's the acronym. And we have one in Wisconsin, and we have the board chair of the All Payer Claims Database, Dr. Tim Bartholow, and the CEO of the All Payer Claims Database, Dana Richardson, here. Our All Payer Claims Database is structured a little bit differently, and so I wonder if either of you would want to comment on what would be helpful to WIO, the Wisconsin Health Information Organization, to make it a more effective resource for the kind of transparency and accountability that Senator Felskowski is looking for.
Certainly. So thank you, Cheryl. So Wisconsin's APCD was set up slightly different than most other states, in that we were set up to be a partnership, a private-public partnership, where most APCDs are at least partially, if not fully funded by their state. Wisconsin does not receive state funding. And so that means that we really have to work quite a bit in the private market in order to be able to, make our budget work. The other significant difference about the Wisconsin APCD is that we are one of probably 2 out of 20 plus APCDs that are voluntary contribution only, which means that we have to work with the health plans, including those health plans that are owned by health systems, in order to be able to bring the data in. And at times, that does constrain some of the opportunities that we have to use the data. So for example, while we have considered contributing to the RAND studies in the past, we have not been able to do that so far. So I guess the 2 primary things that make Wisconsin different is that we are not funded by the state, which means our market view is a little bit different. And also we do have voluntary contribution. Jim, do you have anything to add?
Tim Bartholow, the grateful chair of WEO now, and actually following Cheryl previously. Our state, Chris, as you said, has some variation in pricing, and our state, next to other states obviously, appears to have some variation in pricing, and we probably need to deal with that, and if we want to be world competitive. We also see, for things as simple as obstetric delivery, that some will deliver a child at, for instance, 8,000 resource dollars or standardized dollars, and others will deliver at, for instance, 14,000 resource dollars. That is tangibly a quality problem. When we see that much variation in use of resources in order to, for instance, make stew. It's sort of a market basket approach. And the state needs to be more serious, honestly, and I don't mean the state, capital S, I mean we as an ecosystem need to be ever wiser about how we approach that kind of a quality opportunity.
Thank you. Thank you, Chris. Any parting comments for us here in Wisconsin and Illinois?
Yeah, I think I would just reiterate I think the second conclusion point that I made, that we see a tremendous amount of variation in price and quality. That's maybe a depressing story, if you will, but it's also a potential savings opportunity. And there are lots of examples of other employers and innovators who have thought about addressing these types of problems. And I think there are lots of potential models out there to actually change the story.
Thank you so much.
Thank you.
Great presentation, Chris. Thank you so much. Next up, we're going to hear from Gloria Sachdev. Gloria is the president and CEO and the board chair for the Employers Forum of Indiana, a sister coalition to the Alliance. She also serves as an adjunct associate professor at Purdue College of Pharmacy. The forum initiatives focus, much like the Alliance, on transforming healthcare through transparency, payment reform, benefit plan design, and other market-focused initiatives, including public policy. By background, Gloria holds a BS and a Doctor of Pharmacy degree from the University of Oklahoma and completed a primary residency right here in Madison at the VA hospital. The hospital price transparency study, the work that you just heard about, really began with a call from Gloria. And over the past 5 years, she has worked tirelessly, not only in Indiana, but in other markets across the country, often at her own expense, to try to shine a light on what's happening with hospital prices. You will hear about how the forum has just launched a new tool called Sage Transparency, which is a gift to anyone who is interested in making healthcare high quality and more affordable. Gloria, all of us who care about hospital quality and affordability owe you personally a debt of gratitude, along with the Employers Forum, and it's a delight to call you a friend and a colleague. please come on up. I'm done saying nice things about you. Thank you.
Well, it's an honor to be here, and I have to say, when we first did our hospital price transparency study, and I wanted to see if other employers or other states might be interested, I went to a national conference, and I was at a dinner, and I asked publicly at one of these mics, is anyone negotiating as a percent of Medicare? Happened to go to a dinner. And then Cheryl came up to me and she scrunched down next to me. She goes, we're doing that. I'm like, you are. So we have been allies and friends ever since. Again, my name is Gloria Sachdev. I head up the Employers Forum of Indiana. I've been in this role for about 7 years. And it's been an interesting experience for me. I'm very data oriented. Working with Chris and his former colleague Chapin White, who's now at the Congressional Budget Office, has been deeply informative for us, not just in Indiana, but around the country. So what I'm going to do today is just kind of walk you through our journey. I will be talking about policy, some of the initiatives that we're working on, and then share with you a new tool that you heard earlier. So let's see if this works. Excellent. So let me forward here. So where did our journey begin? As mentioned, I did my PharmD and did my primary care residency here in Madison. I just have to say I've loved being back. We went to the Essen House last night, and I look forward to going to Clausen's tomorrow morning before I drive back to Indianapolis. Went to the Union and Tipsy Cow and all these great places. But our journey began about 7 years ago when I actually have a provider background. So I was working in physician office clinics doing chronic disease management. My husband's a physician as well. He trained at the UW, did his residency and fellowship there in hematology. So we are just naturally data oriented. When I took this position, I was a consultant to the forum and had my own consulting company for about 6 years prior to taking this position on. And in that role, I worked with all the stakeholders in healthcare, if you will. And in this role, I went to all of the employers and said, what's your biggest pain point? What can the forum do? How can we be more helpful or more useful to you? And across the board, every single one of our forum members, all of our employers that is, they all said the cost of healthcare in Indiana is just too high. Many of them had a footprint in other states. So they'd have a footprint in Michigan, for example. We have a lot of manufacturing in Indiana, so the big autos, most of them have a big footprint in Indiana, and they can compare their prices. They knew from their claims data. They didn't really have individual receipt information like Chris was talking about. They just in aggregate would say, I'm just paying 6% more every year on health care, but they don't know why. And so that was interesting to me, is our health care costs going up, and if so, how does Indiana compare to everyone else? So our hospital prices going up is what led to RAND 1.0. We found, and I'm not going to go through the studies in great detail, but we found it was just shocking. We saw a study in 2015. There was no price data available. I'm very evidence-based. The first thing I do is go to PubMed, really, when I'm looking into anything. And there were 2 articles, and they were both written by Chapin White. So we had this idea from an article that he also wrote, which noted what Chris was showing you. Here are Medicare prices, and here are private prices. So we wanted to know, could you just, if we gave you the claims data, gave you what was actually paid, this is not from a database, we're going to give you employer claims data, would you do this analysis as a percent of Medicare? We wanted to see. This was the first time we knew that there was any variation in prices. When I present this stuff, some of the employers are like, are you trying to tell me that different hospitals are paid different amounts? And I'm like, yes, and that's exactly what I'm trying to tell you. But that was the limited lens just 5 years ago. But things have really come a lot further, and I'm excited to share that with you. So with no further ado, I'm going to kind of blaze through some of these data slides because you've seen some of this information already. So oftentimes the hospitals will say, well, why are you picking on us? You know, what about drug prices? They're so high, and they are so high. And I'm a pharmacist, and I'd love to spend some more time on drug prices, and we are. We're looking at PBM legislation. We're looking at different things. But when you look at the cost pie, 31% of it is related to hospitals. So when employers are paying for healthcare, the biggest slice of their cost pie is hospitals. So that's why it makes sense to start there. Also, physicians are the second biggest, and as we've already discussed, many of the physicians are now employees of the hospital, so now it represents 50% of our costs. This is just an updated slide of some information that I saw in 2015. This is looking at, let's see, I think this is a laser pointer. Yeah, so here's Medicaid trend over time since 2008 to 2020. So this is spending for Medicaid. This is Medicare. Medicare pays more also, but this is just growing, and it's at an exponential rate. So this is through 2020, and we can see that private is paying, which is commercial, is paying so much more than Medicare, and that gap is growing. So this is per capita out-of-pocket expenditures. And as Chris mentioned earlier, you know, people are paying more and more out-of-pocket. Employers can't afford health care. In Indiana, we're one of the states with a very high deductible health plan rate. So we go to high deductible health plans, hoping that employees will be smarter shoppers. Well, how are they going to be smarter shoppers? Healthcare is so complicated. They have no line of sight to price and quality information. How are they going to shop for care? Okay, it's just a way to cost shift to the employee, but they can't be smarter shoppers. And there have been tons of studies that have been done to look at, if you give consumers, employees, price transparency tools, does that help them be better shoppers? And the answer is no, they don't use them. It's too complicated. So Castlight and all of these other tools that are available were awesome in the beginning. We really applaud their work, but people just don't use it. It's really up to the employers to look at this data and design benefits and payment models. You cannot dump this on employees. And now they're paying so much out of pocket. Now there are these studies, people don't even want to access health care. They're afraid to access health care because they're going to get their bill 2 to 3, 4 weeks later, and they don't even know what the bill is going to be because you don't know what the price is up front. This is an unreal slide to me. This is family coverage, and as Chris mentioned, as of 2021, it's over $22,000 for a family. And this is looking at high deductible health plans versus not high deductible health plans, because the idea is, well, maybe I shouldn't have a high deductible health plan. I should go to something else. Well, the high deductible health plan, is 20. They're both just. It's still a chronically expensive. I'm looking at 2007, and it was $12,000. I know these numbers are small, and now it's pushing $23,000. This is single coverage, same trend line. Now over $8,000. This is Wisconsin. So this comes from the Healthcare Cost Institute. You can just Google Healthcare Cost Institute. I reference all of my work, so there's the link if you're interested. It has all the states there. You can look up any state that you're interested in. And we hear that spending, which people will call total cost of care, is going up. Total cost of care is going up. We shouldn't be looking at prices. Let's just look at total cost of care. Total cost of care is made up of two things. It's made up of price, and it's made up of utilization, and utilization's just quantity. So what's the total cost of care if I go to Starbucks? My price for a coffee is $3. I'm buying 5 of them. My total cost is $15, right? But just to talk about total cost is not telling you, well, did I just buy a whole bunch of them, or was the price really high? What's the problem? All I see is my total cost is going up. You see the bottom of the receipt. Well, here you can see in this information from the Healthcare Cost Institute that this is utilization, and it's gone up 4.2% in Wisconsin from 2014 to 2018. And this line is price. So utilization plus price is equaling. Look at your trend. It's so steep. You've had a 20% increase in the cost of care over 5 years, and it's actually, closer to 25%. So in another 5 years, can anyone in this room afford for healthcare to go up another 25%? No. So no one can afford it. We're on a non-sustainable track. This next slide over here is just the national trend. It's equally terrible. So this is not a Wisconsin problem. It's not an Indiana problem. This is really a problem across the country. And not in one state is it utilization. It's price. Price is the problem that needs to be addressed. So when I first started, because this is about our journey, Cheryl wanted to hear all of it, the good, bad, and the ugly, we wanted to define what value was. So we had a multi-stakeholder panel, so a little bit about the Employers Forum. We are a 501c3 organization. We have about 150 self-funded employers. Many of them are schools and colleges, manufacturing, just a wide variety, all different sizes, huge ones, small ones. And then we have about 50 other stakeholders, health plans, providers, even a PBM or two, a pharmacy, physician groups, and they're important to be there. They need to be part of the discussion because they are really integral to operationalizing healthcare. This is the employer definition of value. When we had this panel discussion, we had benefit consultants, we said, hey, how would you define value? Everyone kind of said quality and price and patient experience and all these different things. Patient experience, I stick into quality. All of these other aspects. Then a CEO of a hospital emailed me afterwards and said, we define value as value equals quality plus price plus quantity. So that means their value goes up as price goes up. Their value goes up as quantity goes up. But our employer value is high quality at the lowest cost, right? That's just how we shop for everything else. So cost is, again, just price times quantity or price times utilization. So we want the best quality at the best price, and we need to monitor quantity, which is utilization. Chris covered this. This is my only slide on RAND to say, these are really the first of its kind studies that were ever done in the country. So we're on our 4th round. RAND 5.0 will be out. I'm not sure when it'll be out. These are really, the work that Chris does to bring these studies to light is a year's worth of effort. They are looking at each individual claim. Can you imagine billions of claims that are going through and then getting them converted over to standardized prices and percent of Medicare? It's a tremendous amount of work, and we really appreciate all the work that he's done and the partnership that we've had over the years. So we did commission this work. The way it started was, again, employers were like, our prices are high. We put out an RFP. We wanted to see, who could even do this type of work. Really, there's hardly anyone across the country that has the capacity to get tons of data in a secure manner and analyze it. Also, very highly reputable. All the reports are independently done. I don't see the drafts ahead of time. I don't edit them. We just ask them to partner with us to do this independent work. Again, Indiana's had persistent findings. So this is what's disappointing to me. I wish I had a better story to say, hey, we did this price transparency work and our prices are down. And that's not what's happened. Price transparency is foundational. We have to have it. Okay, we have to all have it so we can shop for care. But our prices have just skyrocketed right through the 5 years, right from RAND 1.0 through 4.0. And it's disappointing. Our facility prices in Indiana are 4th highest in the country. Our professional fees are 4th lowest in the country. So we have a very different problem than what you have. You have 2nd highest professional fees in the country. We have 4th lowest. Similar reasons, but it's interesting to kind of go into the market and see why that's happening. And maybe if there's interest in that, I could explore that during the Q&A. But we have 2 different problems, and entirely a different problem than what you have here. But you have high facility fees and you have high professional fees. So you also have 2 problems. So our response has been, two-sided. We're like, what can we do from a market perspective? We need to work with the insurers, we need to work with the hospitals, work with the providers, educate employers, bring in all these people, and then what can we do from a legislative policy section? So the Market Solutions, the Alliance is an amazing organization. It it really is focused on all of these endeavors. And I have some slides a little bit later to discuss that. But the majority of what I'm going to talk to you today about is what we've done from a legislative perspective. And I hope this is helpful to you because I heard some questions about that earlier. So in 2019, so RAND 1.0 came out in 2017. It was just Indiana data. And our prices were we had 120 hospitals, and our price was 272% of Medicare. And I was like, I thought it would be like 20 or 30% more than Medicare. Honestly, I'm like, why are employers paying over almost 2-3 times more than the exact same procedure for a Medicare patient at the exact same hospital? I could not wrap my mind around it. I met with all of the hospital CEOs, the large health system ones, one-on-one. We brought in Chris and Chapin on, the microphones in the offices in case they had a weedy data question that they could answer it. And the question was, why are these prices so high? And we had the health systems, and we could see with all the hospitals within their health system, the prices varied so much. Like, why is this one getting paid 250% of Medicare and this one 400% of Medicare? Why? Like, why are these prices like that? They didn't have really, it's just evolved that way. It's not, I don't think, they didn't even really know, to be honest. They knew their prices, but they didn't know how high their prices were compared to anyone else. Every one of those hospital CEOs and CFOs had signed a contract with the insurance companies and included something called a Gag Clause. The Gag Clause prevented either party from disclosing the negotiated rate even to the people paying it. Can you imagine? So you hire me, go get me a coffee. I'm like, okay, how much are you going to give me? I'm like, you should give me $50. Okay, and then I come back and I'm like, well, it was $50, and you're like, can I have the receipt? And I'm like, no. So that is our healthcare market today still. You don't get that level of detail that you need to be a smart shopper and to do your fiduciary responsibility. So we wanted to start unpacking all of this stuff. It's a runaway train. The market, we've been working, it's not going to fix itself. So it wasn't until 2020 when we had RAND 2.0 that came out in 2019 that found that Indiana was the highest priced of 25 states. I mean, that just blew everyone's socks off. We're like, we're in Indiana, we're in the middle of the country, like, why? Why are our prices the highest? It makes no sense. RAND 3.0 came out, and we were the 6th highest overall, still, out of 49 states. Why? Why are our prices so high? And I'm sure you guys are asking the same thing, like, why? Why is there so much variability? Why is it not, doesn't correlate with quality? What are we going to do about it? So with that, here's some of the stuff we did about it. We prohibited gag clauses. You can't have a gag clause. So when an employer is asking you, the payer or the hospital, tell me how much I'm paying for orthopedics or this procedure, you have to tell them, okay? This is common sense. Price transparency. We required hospitals and ambulatory care surgical centers and urgent care facilities to post prices on their own websites. This is before the federal law came into place. The hospitals said, we're going to sue. You can't make us put our negotiated prices on our websites. That's proprietary information. That is not proprietary information. You can look up the price for anything. You can look up the price for a pen, a water bottle, a car, a fridge. You can look up the price before you purchase something. It's not proprietary. There's nothing secretive about price and quality information. So we did it as a weighted average. We put it in statute, and we said, okay, do Medicare, Medicaid, cash, and weighted average. And you have to post that on your website. We have a lot of our benefit consultants. I'm hearing this is a chronic problem across the country. It's certainly a problem in our market. Not all the benefit consultants, but a lot of the benefit consultants, they get paid by the insurance companies 6 figures to promote them. So if I'm an employer and I say, I need a wellness clinic, or I need an on-site clinic, or a disease management service, or a sleep service, or, a PBM, or a carrier, or TPA, they will accept money and not disclose that to the employer. So you think they're your trusted advisor. You are saying, bring me back the 3 most qualified organizations, and then we'll review them and meet with them together. But to just get into the door with the employer, they're essentially paid off on the back end. It makes it really hard for innovators to enter the market. And I've heard from so many startups and innovators, they didn't budget enough money. They didn't even know they had to budget money to pay off the brokers, but they did, and they do. And that's unfortunate. So we required that benefit consultants, we wanted them to have to fully disclose everything, all financial arrangements they had with any vendor that they were going to mention to their employer. They had to tell them. It got switched at the end, and unfortunately, it's still good, but just the insurance companies now had to, it put the onus on the insurance companies. The insurance companies have to tell what the broker is getting from them to the employer, if that makes sense. That's because we had 7 legislators that were brokers. Okay, so that's how these things work out sometimes. All payer claims database. We were a state that didn't have an APCD, so about half the states in the country have an APCD. We understood that price transparency is really important, and we passed it. So where we are with our APCD process, we passed it in 2020. It was a non-budget year, got funded the next year. Then we started putting some structure around it. The RFI has gone through, the RFPs just finished up, and now they're going to make the announcement of who their APC vendor is going to be. I'm anxiously awaiting to hear who that is. So I think this is an important piece legislatively. In our APCD, we, the forum, did an analysis of every APCD in the country. It's on our website. You can see all the APCDs, one pager on each of them, what their legislative limitations are, how they're financially funded, when they got established. And one thing was really clear. Some of them in statute specifically said you are not allowed to show prices at the provider level. Well, what's the point, of an APCD if you can't show it at the physician or hospital level? So it doesn't help an employer to say, well, the northwest part of Indiana has higher prices than the southeast part of Indiana. That's not helpful. You can't shop based on that. So you need to have it. We were very specific in our statutes what needed to be in there, what didn't need to be in there. From a legislative perspective, we are putting in Medicaid, Medicare, and all fully insured. You cannot require by statute to require self-funded employers to put their claims data in any APCD per Supreme Court ruling. They can voluntarily do it. But they're only going to do it if there's a strong value case for them to do it, right? And so that's something we'll be working on, is defining that value case so that we have a really robust, hopefully best-in-class APCD. We also passed into law good faith estimates. If I need LASIK surgery, which, I would like to get one day, I just have no idea, how much it would cost. And I would like to be able to call 5 different places and say, how much is it going to cost for me to get LASIK at your place? And so now they're required to provide a good faith estimate. They can't provide an exact amount, but at least a good faith estimate. We had some more teeth in there to say it can't be more, your final can't be more than 10% of your good faith estimate. Some of those things got taken out, but it's a good place to start. Surprise billing, I heard that mentioned. This is a total war at the State House. Total war at the State House. Who knew? It was just common sense. If I go to an in-network hospital, that's the best I can do. How am I supposed to know that the radiologist or the pathologist or the anesthesiologist is out of network? So the hospital's in network, but they are contracting with out-of-network providers. Then those out-of-network physicians are balance billing the patients thousands, tens of thousands of dollars. It's so wrong. It was just bankrupting Hoosiers and people across the country. So we prohibited it. We did not address the payment piece. We said, the hospitals and the insurance companies can figure it out. There was this whole discussion of arbitration versus making them pay the in-network rate, like pay the in-network rate for that facility because it should all be in-network. So that's what we supported. We wanted them to say, you're at an in-network facility, you get the in-network rate. You don't get like an out-of-network rate at an in-network facility. Now, if you're an out-of-network hospital, then you get the out-of-network rate. But you're all in or you're not. You can't just like splice it 10 different ways. Site of service, I'm still hoping that we get this one. I'm actually hoping we get this one across the finish line this year. We've been trying since 2020. This is saying that if you're a hospital, you can bill as a hospital. But if you purchase a physical therapy office in a strip mall 10 miles away, that's a clinic, and it was billing as a physician office clinic. Just because you bought it doesn't mean you get to charge hospital rates for that. Okay, so it's site of service. Site of service, they have, we went about it the wrong way, honestly. So here's a lesson learned. You know, we were saying fill out the right billing form because clinics fill out a CMS 1500, and then hospitals fill out a 1500 for their professional fees, but they also fill out a UBO4, oftentimes known as a UB or a CMS form 1450. But just the hospitals fill out that form. So we're like, don't fill out that form, just fill out the other form and mark that you're a physician clinic. You have to do that. Well, where's the enforceability in that, right? They're like, oh, that's administratively burdensome. We're not doing that. Anthem, our largest carrier, had mentioned that it was going to be a $100 million savings to our employers, so we thought we would move forward with that. The Hospital Association said it was a $2 billion savings for us, and so we didn't even realize that it was such a big problem till the Hospital Association told us this. So it was really eye-opening that, and they were like, oh, we'll lose so much money. I'm like, this is not even your money, you know, this is the employer's money that you should have never been billing like that way to begin with. So that bill died. It passed the House, it passed the Senate. The very last committee, I want to say about 500 hospitals and their partners showed up in white coats and pressured the legislators, and then the bill died. So there was an amendment offered, and it stripped it all out. So, yeah, I don't know how your legislative process works. I hope your processes are better than ours. Our legislators are awesome. Our processes need improvement. So I wanted to say about these bills real quickly. So this gag clauses, all these bills, we passed them in 2020. They're all federal law now. So at the end, in December of 2020, all of these became federal law, which is awesome. APCD, there's not a national APCD, but they have funding, they allocated funding. Actually, they passed a rule to allocate funding for APCDs. My understanding is they haven't given that out quite yet, but every state can apply for that. So that's something that perhaps your state could do, is say, hey, what is the federal funding opportunity? How do we get some of that money here? The state could start funding the APCD. That would allow them to have more opportunities to say what goes into it. Being a totally independent APCD is a struggle from what we've seen from other APCDs. So I think there's opportunities to shore up your current APCD and help them out. So prohibiting gag clauses, federal rule. Price transparency, as you know, starting 1/1 of 21, all hospitals have to post all of their prices at the negotiated level. You can go to any hospital and you should be able to see what their prices are at the procedure level right now. Now, it may be hidden, it may be hard to find, it may not be really easy to read, but it should be there. It's a federal rule. It's been around now for a year and 5 months, so they all should be 100% compliant. Many of them are not compliant, and the reason is the federal government has not issued a single penalty. They've increased the penalty, but they haven't even given one hospital a penalty. So that's another opportunity at the state level, is say, if you're not compliant with your the federal hospital price transparency rules, then the state is going to implement a financial penalty. And we will be looking to do that next legislative session in Indiana. We talked about the benefit consultants. So benefit consultants now have to disclose all of their financial relationships with their employer clients. We talked good faith estimates are now federal rule. Surprise billing is now federal rule. There should be no surprise billing happening in Wisconsin. If there is, somebody probably should be talking to an attorney. And so site of service, we have CMS addressed this, which is really exciting. They just put, this is amazing. I said we did it the wrong way. They did it the right way. So CMS passed site of service, which they call site neutral payments, in 2017. The American Hospital Association, other hospitals sued the government. It went through the court system, went to the Supreme Court last summer, and the Supreme Court stood down the appeals court. They're like, we're not going to hear it. So when they say we're not going to hear it, the next lower court's ruling stands. And so site-neutral payments went into full effect in the fall of last year. All they do is pay them differently. Instead of fussing with the forms like we were doing, they say, well, you're not going to get paid. We're just going to have two different ways you get paid facility fees. We know you're a clinic, you're going to get paid a lower facility fee because you're a clinic, so that the prices are equal. So that's site-neutral payments is what they call it. And we'll be going for that next legislative session as well. Yeah. Oh, okay, thank you. I told her I could just go on this stuff forever, so I'm going to zip through some of these. The biggest thing we did in 2021 was we required all not-for-profit hospitals to have a public meeting, kind of like a school board meeting, where they have to discuss their finances, and it's delineated in statute. Also, the insurance companies have to do this. And then we were working on some of these other issues. Our legislators have been awesome, real heroes in this space. I just can't say enough. So the Speaker of the House and the Senate, President Pro Tem, wrote joint letters, sent them to the largest 8 health system CEOs and the insurance company CEOs in January of this year, said you need to work together and get your prices to the national average, or we're coming in heavy and hard next legislative session. These letters are publicly available. You're welcome to read them if you'd like. They had to submit a plan by April 1st of this year, so just a month ago. And they had to say what their plan was to get their prices to the national average. What we found, what happened was, and you can, we have them on our website if I don't have them here, or you can just Google it, what all the plans were, what all the hospitals' plans were. So the largest one in the state agreed to come to the national average, and the second one agreed to lower their prices, and the rest of them didn't agree to do anything. So I think our legislators are really not happy with the response that they received. So in 2022, because our legislative session's January through March or April, depending on the year, those letters came out, the plans were due in April. We didn't do a lot. Our legislators want to say, hey, let's give them time and let them submit a plan, let the market correct itself. Market doesn't want to correct itself, and that's what we saw here. So we passed a few other bills. The biggest one probably was around workers' compensation. We have a cap as 200% of Medicare already on the books. And this is a Republican supermajority state, and we already had a cap at 200% of Medicare for hospitals in the workers' comp space for several years, and now we added ambulatory surgical centers as a cap. So our legislators are looking at a general cap possibly for next year. So there are the plans if you're interested in that. And I have to tell you, ever since the legislative session came out and these plans came out, it's been in the press all the time. Everyone's trying to control the narrative. Here are all the articles just since January. I think I have one from December. The rest are since January. This is IU Health talking. This is us, the Employers Forum of Indiana. This is legislators. This is insurance companies. And then there's more. I mean, here's like 36 of the ones that I found, and they're all hyperlinked in case you're interested in seeing what's happening. But they're in local papers, they're in national papers, they're everywhere. And then most recently, the IBJ Forefront asked me to write a 500-word essay on what I thought needed to be done to fix healthcare in the state of Indiana. And they said, we're asking other people as well, but we're not going to tell you who that is, and then we're going to publish it. I'm like, okay. So I sent it in on Mother's Day, really late, and there's my 500-word essay. I'm recommending enforcement of price transparency, site-neutral payments, and implementation of price ceilings. The other two people were the president of IU Health, our largest hospital system, and our Speaker of the House. And so you can see what their recommendations are as well. So that's just an overview of, we've been very active legislatively. We've had to be because the market As I said, we've had price transparency. We're educating employers. We're talking to our insurance companies. We're talking to hospitals, and prices still keep going up. So we are still doing this, what we're now seeing, and I know the Alliance does this very well, so I just have one slide on all of this because I believe you guys have discussions about this routinely, is where we have a lot of employers interested in direct contracting with the hospitals. They're like, well, I think I can do a better price negotiating my prices versus going through a carrier. And they're looking at bundle payment, centers of excellences, narrow networks, tiered networks. They are really focused now on making data-informed decisions, not listening to all of their consultants and brokers. They want to see the data, which is super important. And they're putting performance guarantees in, which we strongly advocate for. If you have any company coming to you and saying, you're going to save 20% if you do this, or your patient's diabetes are really going to improve, make them put it in writing and make them give you a 100% refund if they don't accomplish that. If I bought a refrigerator, a really awesome one, a Sub-Zero, and they delivered it and it didn't work, I would send it back. I wouldn't just keep buying more refrigerators, to put in my kitchen. So I think we need to start thinking of healthcare like we think think of everything else. So on May 5th, we had a National Hospital Price Transparency Conference. We had 560 attendees, and we highlighted for the first time Chris's great work with RAND 4.0, and we also launched Sage Transparency, which is freely and publicly available. It is sagetransparency.com, and this was a project funded by Arnold Ventures. We built it. We partnered with Mathematica, who's our IT vendor, to actually build it, and it's just been we're just super excited to share it with you. So I want to tell you it's made up of 5 different data sources. RAND 4.0 prices are in there. So I don't like Excel spreadsheets, and he posts Excel spreadsheets all the time, and I don't like them, but he likes them. So I need pictures and graphs and something easy to use. And I used to get calls all the time. Gloria, what are the prices in this area? And now we just wanted to make a simple tool so everyone can look up their prices. So in addition to having RAND 4.0 prices, which are what employers and insurers actually paid, we also have NASHP, the National Academy of State Health Policy, has published their own tool a month before us. They look at hospital financial reports that their CEOs and CFOs sign off on and submit to Medicare. It's their costs and their revenue, their payer mix. It's all their information that they've submitted. And then Marilyn Bartlett's been the champion there, and she has just taken all that information and made it easy to use. So I would encourage you to go to her website, and we pulled out a couple of pieces there. But what she's showing is something called commercial break-even. What does the million-dollar question is, what's a fair price, right? Okay, you're getting paid 300% of Medicare, but what's the fair price? Well, it depends on what their costs are, right? And so what she has is costs as a percent of Medicare. So if the cost is 150% of Medicare, but you're paying them 300% of Medicare, that's your room to negotiate on prices. But it varies a lot. It's really surprising. We heard about CMS hospital star ratings. Those are 3 public resources that are data sources that are in Sage. Turquoise Health is a proprietary solution, and we are just using some of it. Hospitals, as we said, have to post their prices on their own websites. Turquoise Health pulls all those files down for over 4,000 hospitals, cleans it all up. I just license it from them, repackage it, and put it in Sage Transparency and make it freely and publicly available. Quantros is also proprietary. It's a quality solution. So they have a lot of in-depth quality data. We're just using 3 of their measures. So this is just, so you can be familiar with some of the features of it. You can export things into a PDF. You can click on these little boxes and it blows up so you can see it on your screen. We are updating this every quarter, so we want your feedback for how it can be more useful to you. So there's all different features here. And so here's our disclaimer saying that we're doing our very best to provide hospital price and quality transparency to everyone to our best knowledge. This is all accurate, but we're just pulling 5 data sources together. So if you really have problems with any of these data sources, please go to them and send your complaints to them. Okay, so with no further ado, would you guys like to see Sage Transparency? Okay. Here it is. Okay, you guys can see this. So if you wanted to, you can go to dashboard.sagetransparency.com. You get directly into the dashboard, and there are 5 tabs here. Okay, so here we have a hospital directory. If you wanted to look up any information, all the information we have, or most of the information we have on any hospital, you just pick the state. And you can see we've got, all the states here plus DC, and then you pick the hospital. And what you will get, I'll just leave it, it defaults to Indiana and Ascension, and one of the Ascension hospitals. So here, that's where the hospital is located. It shows that they see 60% commercial. They have 16% Medicare, 13% Medicaid, 7% Medicare Advantage. They provide 4% of their revenue is charity care, and they see 1% uninsured. That's really helpful to us because a lot of the hospitals will say, we provide so much charity care. We see all these uninsured patients. And I'm like, well, do you? Do you really? Because we never had line of sight until NASHB put this out. So this is very helpful to us. Some of our hospitals only have 1% charity care, which is so surprising to us, and no uninsured, which is also surprising. But you get an idea of how much Medicare and Medicaid they have because they say we can't make it on Medicare and Medicaid alone, so we have to cost shift to the employers. Here's some quality information. Here's Quantros. So this hospital's doing pretty good. They're getting close to 80% on overall Medicare, overall medical care, hospital care, surgical care. These are CMS star ratings. It's out of 5, so they've scored 4, and they've got pretty good patient experience. But these are the prices. Here is their hospital's prices. Here's the state benchmark, and then here's the national benchmark. So you can kind of quickly see, okay, their total facility, which is the hospital, is 344% of Medicare. That sounds really high. The state of Indiana is 329. So they are above our state average, and then the national average is 260. So Indiana has a problem, and their problem, their prices are higher, even within the state. But this is what I really like. This is the NASHB number, which shows what their break-even price is. So it's 145% of Medicare. Our state is 161, and the national is 127. We're going to put out a hot release so that the y-axis is fixed, so it makes it more visually clear. You can also search by clinical categories. Like, let's say you just want to look at MRIs or cardiovascular care, emergency room, GI, laparoscopic, circulatory. So you can start looking at prices, and these are the prices that they have posted themselves, and all we did was convert it to a percent of Medicare. So these are the prices they have posted themselves for these services, and you can hopefully shop for care. So you can look by hospital system as well, and for example, you could pick Ascension Health. You could pick Ascension Health. You can pick certain states. Right now, it's selecting a lot of them. You can look at hospitals by state. You can look at clinical categories only or just state. I think from a legislative perspective, policy perspective, this high-level information at the state is really helpful. So let's add in Wisconsin. And you can compare, let's say, Wisconsin to surrounding states if you wanted to. I'll just put in Wisconsin. Okay, and just like that, Wisconsin is 4th highest for total facility plus physician. Indiana is ranked 7th, Ohio 18th, Illinois 21st, Kentucky 39th. These are the highest, these are the lowest, but let's say you just want to look at professional fees. So we have prices 9 different ways from Chris's great work. Let's look at total physician, which is inpatient physician plus outpatient physician. I believe he said you were second. Yep. And so here's Wisconsin at second highest, but then you can see how you compare to other states in the country. It also puts it in a graph for you, and you can export these, but you know, some of these things are, and then here's the NASHB price. So here's what it would cost, and then there's the top numbers, what you're paying. Here are all the prices together. So you can see what all the prices are, all 9 prices, just by hovering over it. And you can export all of this into a PDF. So all of this is just freely and publicly available. I'm just kind of going over it at a very high level because you'll want to just spend some time with it. Okay, so that's all I have for SAGE. Any questions about SAGE transparency? Yes, Chris.
The gap between the price and the national price, does that represent margins?
Yes, so that's a great, yes. I'll repeat the question. So the question was, the price between hospitals, what the hospitals are getting paid, which is from the RAND studies, and what the NASHB break-even price is, what does that difference mean? Is that hospital margin, was the question. So let me pull up, should we pull up Wisconsin? Why not? Okay, let's pull it, I think I can just type it here, W-I-S-C. Okay, so we'll just pick Wisconsin. I think it also keeps Indiana. So let me get, oh yeah, it did keep. Okay, show selected values, let's X out of Indiana. Okay, what I want to show you here, and we could pick a region. Let's pick Madison. So you can go by regions. Let's see, Milwaukee, where's Appleton, Chicago? Janesville, where's Madison? Oh, there it is, okay. So let's deselect all. Let's just select Madison and see what hospitals are in the Madison, Janesville, Beloit area. So here they are. And what you can see here is that this is the total facility, what the hospital's getting. And then this is the NASHB break-even. So this is really high. They're getting paid 390% of Medicare. Their commercial break-even's 273. So that difference is what that margin is where you should negotiate. I'm not saying that they should get commercial break-even. I'm not saying that because they need to make a profit. They need to make a profit so they can keep their doors open. But do they need to make, I don't know what hospital this is, but here is 96% of Medicare, and here they're making 305% of Medicare. So potentially you could negotiate with these hospitals down. Now these are doing pretty good, right? The difference between their break even and their actual price is pretty small. Some of these, it's quite a bit larger. So that's how you interpret the information. Fully loaded costs as they report them, fully loaded. So you can look at costs in a lot of different ways. It's an excellent question. Marilyn Bartlett, who created this, presented at our conference, and we posted her presentation and everyone else's on our website. So if you're interested in learning more about this, I would encourage you. She gave a 20-minute presentation kind of going through which costs and what costs, but these are fully loaded costs. Okay, excellent. I want to see, so now I'm going to pull up my slides.
We do have a question from the webinar,
Okay.
which is just what is the reaction to the inclusion of the NASHB data into your tool from hospitals?
Could you repeat the question? What is the value?
Oh, what is the reaction from hospitals on the NASHB break-even point?
I mean, I think everyone's still digesting this. This came out a couple of weeks ago on May 5th. We have not had not one single hospital's reached out and said anything about it. NASHB has been beta testing this for over 2 years. So we were part of their beta test. They've been working with hospitals across the country on this. And they have a written form called the Hospital Cost Tool. So if you go on the National Academy of State Health Policy Hospital Cost Tool, it's got all of their methods and everything all written out. Everyone wants to talk about the market. We want the free market to work. You know, we want it to work. But it's not working now, and it's not going to work. I mean, a market only works if you have choice. If you go to a grocery store and you see a potato chips aisle and, you know, one bag of potato chips is $40, you know, you have the line of sight to price and you're like, no, I'm not buying that one. You know, I'm going to go to the $4 one. So you have to have, it's based on choice. And right now, people don't really have choice. They're not making a data-informed choice. They're just going. They ask their family and friends, like, where should I go to get this procedure done? And that's not very data-oriented. We have to have 100% price transparency. It's foundational, but we need to be clear, price transparency, I mean, we are living proof, Indiana. Price transparency in and of itself is not going to address healthcare prices. You just need it to start using it and making decisions. We need legislation because the horses are out of the barn, and we need to start reining some of that in, and we talked about putting up some guardrails here. I also want to say a lot of providers have stepped forward. We have not had pushback. We've had a lot of providers step forward and want to be part of the solution. They are the high-quality, low-priced hospitals, and those are the ones that we need to start partnering with. It will create that competition in the market. You know, if people start moving their employees to the best quality at the lowest price, you will start seeing prices and, you know, go down and quality go up because people want your business. And so for employers, it's just very important for them to be evidence-based and have a partner that's really data-oriented, that's going to be looking at quality and prices and utilization and waste. And I can't emphasize that enough. It cannot be the partners who are providing that service. It has to be an independent organization because they are always going to tell you that they're awesome and that they're doing a great job. So the Alliance has all these services, and I think Wisconsin is really poised to do well over the next couple of years. So with that, now I'm happy to take any questions.
Questions for Gloria?
Yes. Oh.
I'm a former journalist, so I always have questions.
Where are
Where
you?
did you
Oh,
get
there you
this is the Holy Grail. You guys have found it, and you're making it available to the rest of us, and I just really appreciate it. I mean, this stuff, we've been aiming at this kind of stuff in Wisconsin for, what, 20 years, Cheryl? And we haven't got it yet. And so this is a nice, you put it all together in a beautiful way. How did you get the support, the political support, the business support? You're a forum.
Yeah.
You know, did you have the business lobbies behind you? Did you have the big corporations behind you? How did you get the muscle to get all of this stuff through? Because our business lobbies are inert, you know, on the subject of health costs.
It's an excellent question. Ours were too. So our employer lobbyists followed their industries. If they were in manufacturing, they followed the manufacturing bills. If they were in education, they followed the education bills, right? But none of our employers were following healthcare bills. So not until 2020, that was the first time any of the legislators recalled seeing any employer testify regarding healthcare. They had no idea. So the narrative was 100% being driven by the supply chain, not the purchasers. I just shared that with our employers. We did a big concerted effort to, I would say our employers put out a big effort to educate their lobbyists. We had weekly calls with lobbyists just to help educate them. We brought in a lot of subject matter experts nationally. So we just did loads and loads of education, basically. Like, what are the topics? What does it mean? You know, here's a one-sheeter on it. And a lot of our employers, several of them ended up testifying. Not just the lobbyists, the actual employers, because they were most familiar with the data and could answer the questions. What was the question?
Who's the forum made
The
up of, Gloria?
forum?
Like, who are the big employers? Is it large employers, small employers?
So the ones that are at the State House are only our large employers, and we had one middle employer, and now we have a cooperative of 50 small employers, and so the smallest employers and medium, they don't have lobbyists. Right? The forum didn't have a lobbyist, and so, but all the hospitals have lobbyists, and the hospital association has lobbyists. So we have tried to educate ourselves. Just this past year, we contracted with a lobbyist part-time I don't live at the State House. You need someone there that's going to be able to answer the questions. So we use Purdue University. was there educating. We had Eli Lilly and Company, and they were really, you think, oh, they're a pharmaceutical company, how do they feel about drug prices? But at least on the healthcare prices, the hospital prices, they were there testifying and supporting us. We had Monarch Beverage, which is a smaller organization with about 800 employees. And so we didn't need a lot. They just needed to hear from some. Some of the other employers, especially the schools, they did not want to get out in front at the State House because they get funding from the state. It's just, could be problematic for them. So they were just helping on the backside. The biggest thing everyone did was contribute their claims to RAND. So we could just start looking at the data as a whole. And it doesn't say it by employers. So politically, what happens in towns, especially small towns, I don't think Wisconsin's that different from Indiana, is you have the board of the hospital and the employers' boards oftentimes will have people cross-pollinating. So people get concerned about that, but they can't be, not anymore. Price transparency's here. Everyone's going to be obligated to use it. Otherwise, as Chris said, I share his sentiments that lawsuits will happen in the next couple of years.
We're going to make time for one more question.
So my question is, what role, if any, did your TPAs and your insurance companies play in this whole process?
So at our State House, the narrative for the past 30 years, as I understand it, has been anytime this is what they've told me, anytime there's been a discussion between the TPAs and carriers versus the providers have won. Our legislators don't like, for whatever reason, the insurance companies. They are public, and you can see that they're making billions and billions of dollars. Most of our hospitals are not-for-profits, and so you kind of have to dig for the information, but they're sitting on billions as well. So they have been there, they have testified, but sometimes they're like, you know what? They tell the legislators that they're there representing employers, and the legislators don't believe them. That's what happens.
We're actually going to do informational hearings in Wisconsin around that very subject, that if you're going to mandate or you're going to prevent white bagging, you're going to do all these things.
Oh, white bagging, oh my gosh.
Yeah, we already killed it once.
Good.
But what our legislators don't understand is the insurance companies is a pass-through.
Yeah, it's 100%
So if
pass-through.
I prevent white bagging, I'm telling my employers they can't do it.
Yeah.
And that's a correlation that a lot are missing.
So our legislators, white bagging became a huge issue. I have a 3-pager that we sent to all of the insurance and health committee members. I'm happy to share that with you if you would like to share it with your colleagues.
All right, Gloria, we're going to leave it there. We
Okay.
could talk for a lot longer. I know we
know.
could, but I want to thank you so much for the work that you've done and for being here today.
Thank you.
All right, we are going to take a break. We will reconvene at 10:30.
So, John Torinas, where are you, sir? CEO of Serigraph, he's here. He asked the question before, and his question was, so in the 401k space, I am the CEO of Serigraph. I'm managing $70 million worth of pension fund. We get sued for very small percentages of difference. What will happen in healthcare with such incredibly differences between the break-even of the hospitals, like Gloria just showed us, and the NASHP tool, and we'll see more of the NASHP tool coming up over the next few months. What will happen? So this definition of fiduciary, this is something that we as employers have been saying. We're the fiduciaries of our self-funded plans. I don't know that we totally 100% understand what it means. So what I want to bring is an expert team of people, and it's a team of 2, but we're gonna just get Jamie today. So Jamie Greenleaf, can you join us? Oh, she's here, Jamie. All right. Well, I wasn't looking high enough. So Jamie Greenleaf and Hugh O'Toole are 2 incredible individuals I met through the Center for Board Certified Fiduciaries. And this is an organization of fiduciary experts that are selected for their fiduciary skills, best practices, and knowledge. So Hugh and Jamie are the healthcare plan leaders, practice leaders for the Center for Board Certified Fiduciaries. And I want to say to you that at the Alliance, we have chosen them to help us certify in our fiduciary responsibilities on behalf of the 305 employers that we represent. So I will personally be going to get the initial coursework before I can get my certification. So Jamie Greenleaf is the founder of Tilt, and she has spent her entire professional career acting in a fiduciary capacity, helping employers design and implement retirement programs with better outcomes for employees. She founded Tilt in 2019 with the same aspirations to bring fiduciary capabilities and strategies to self-funded health plans. And she's going to help us today talk about how to cut and control costs while providing better benefits for our plan participants, our employees and their families. She's working with employers and brokers, advisors to establish fiduciary processes and to mitigate the risk for the plan sponsors while enhancing transparencies. She is very much sought after. In fact, Hugh is not joining us today because he had a different, he was, I think, triple booked. Jamie is out of New York, and early yesterday morning, we get the word that United has canceled all flights coming into Madison. She was supposed to, she tried to come into Chicago, 6 o'clock in the morning. It didn't happen, so we told her to stay put in New York, and we're gonna bring her in virtually. So she's joining us virtually. Well sought out speaker on pensions and investments, HR.com, SHRM, University Conference Services. She also serves as a adjunct lecturer in the Plan Sponsor University Certification Program for UCLA's Anderson School of Business Executive Education. So yes, we messed up the slides. Yes, that's me. You all know me, I think. And here's Jamie. Jamie, it's all yours with a little bit of a delay.
Okay, great. I'm going to get started. I am so sorry that I'm not there in person. I truly wanted to be. Travel, unfortunately, was just not working. But I am excited to be here. As you might know, my name is Jamie Greenleaf, and I'm the co-founder of One Vision and also the founder of Tilt. And we're really advocates for employers to help them implement fiduciary processes around their healthcare plans. And in doing so, we know that they're going to reduce their risk and liability associated with their ERISA-based plan, as well as control their costs and enhance the programs that they're offering to their employees. So the intent today really is to help you as a group understand the regulatory environment that we're living in today. And I know some of the previous speakers kind of talked a little bit about that, but we're really going to dig into the weeds on a couple of pieces. In doing so, our job is to help you understand that you now need to establish a prudent process to minimize the risks associated with some of the new things going on in the regulatory environment. We know when implemented properly that this is going to improve the plan for your participants, and that's ultimately our end goal, is how can we do and act in the best interest of the participants. So I'm going to take you back about 20 years ago. I actually grew up in the retirement space. My mother founded a firm called Cafaro Greenleaf back in 1981, which was right around when the code 401k came kind of to fruition. And when I got out of college 30-some years ago, I started talking to people about saving in this thing called a 401k or 403b. And they kind of all looked at me like I had three heads, saying that, you know, the reality is that we had pension plans and we had profit sharing plans. So, you know, why would I put my own money into something called a 401k? But what happened is that there were brokers and TPAs and mutual funds that were involved in this environment, the 401k environment. And it was muddy. It was very muddy. There was lack of transparency on what people were paying. And about 20 years ago, a new regulation came to fruition called the 408b2. Many of you may remember this if you sit on your committees with your retirement plans. And prior to the 408b2, we found that employers offered a lot of funds within their 401k and 403b. They thought the more choice that they gave to employees, the better. We also found that the people that were doing the education, that were on site at the facilities to help people understand the value of saving in a 401k plan, were commissioned salespeople. So there was a lot of ancillary products being sold to the end user, that employee. We saw that the average cost to employees was running anywhere from 2.5 or 250 basis points to 3.25. And in some cases, we saw termination fees associated with it as well. So what was happening is that the fees were eating up the returns that participants should have received. We had low participation rates, and companies were running with high liabilities. So the outcome, unfortunately, prior to 408b, is that we saw lawsuits because there was no prudent process around how they managed the 401k or retirement plan. And unfortunately, these lawsuits had large settlements. After transparency came to the marketplace in the 408b regulations, employers started to establish prudent processes. And keeping in mind, as a fiduciary, you have to establish a prudent process, adhere to it, and then document it. So they started to do that. And in doing so, they started to customize their education and communication because they knew it was important to have the right and the appropriate number of funds and the appropriate people talking to their employees. The average cost significantly dropped to employees and now is running less than 50 basis points or 0.5%. We saw transparency in fees and services, so enhanced services, and you actually understood what you were paying for and who you were paying for. Through plan design, we saw a lot of higher participation, more proactive ideas came to the surface, which created higher deferrals. In adhering to this prudent process, we reduced company liabilities and ultimately provided better outcomes. Employees started to save with the average account balance now being over $100,000, and they were actually they were able to retire with dignity on their terms. So when the stakeholders align, good things happen. So that's basically what has happened in the kind of regulatory environment. The government recognized that by adding the transparency into the retirement space, that better outcomes came about. So they felt that perhaps utilizing what they had already seen in the retirement space, they would do the same thing in the healthcare space. Now, keeping in mind that ERISA has always overseen both healthcare as well as retirement, but there's been some limitations as to what fiduciaries could do on the healthcare space simply because of the lack of transparency. So the three pieces of regulation that are changing that right now are the hospital price transparency, which you heard a little bit about. That is in full swing, and as you've heard, the penalties are not that much and they haven't really been implemented. So still we see a lot of hospitals out of compliance. The Consolidated Appropriations Act, or the CAA, is like what we like to call it, and that is in full swing. It was actually signed in 2020, December 27th of 2020. And then the Transparency and Coverage Reg, which is going to provide additional transparency to consumers so that they can start to understand what the cost of care is and be able to shop for that cost of care. Unfortunately, the CAA and the transparency and coverage become an employer's responsibility. So we're actually putting the big F into fiduciary for the employers. So the question becomes, why hasn't anybody heard of the CAA? Or why, when I talk to people, mostly employers, and even some of the providers, we find that 90% of them have not heard of the CAA? Well, it was signed by Trump in 2020, December 27, 2020, but it was the longest bill ever passed by Congress, almost 6,000 pages. And it was $2.3 trillion, one of the largest spending measurements for COVID relief and economic stimulants. There were 90 pages that talked about transparency and reasonableness in the health benefit industry. And that's why we feel that most employers haven't heard about this, because it was such a large bill and such a small percentage or pages were actually dedicated to the transparency and reasonableness of the healthcare spend. But guess what, guys? It's in full swing, and most employers only have 6 months to make sure that they get into compliance prior to some of the penalties, and more importantly, we know that some of the lawsuits are going to start kind of piling up because we saw it in the health and the retirement space. So let's jump into the 4 pieces that you should be aware of under the Consolidated Appropriations Act. The first is the removal of gag clauses from all of your service providers' contracts. This is prohibited language now, and we're going to talk a little bit more about that. You're going to have to establish new reporting requirements around your pharmacy and prescription drug disclosures. You're going to be receiving disclosures of direct and indirect compensation from all of your service providers. And now under 408B2, you as employers are going to have to deem them to be reasonable or perhaps have a prohibited transaction. So we'll talk a little bit about that too. And the parity in substance abuse and mental health has been in effect for many, many years. The reality is that the enforcement is going to be enhanced under the CAA. So we'll touch on that. And that's an extremely complex area, both that as well as the pharmacy spend. We actually just ran a 2-hour workshop for a group of employers around these 4 components. So a lot of meat here, but hopefully today will give you some good actionable ideas to take back to your office. So let's talk a little bit about the removal of gag clauses. Now, when I first read this, removal of gag clauses, the hair on the back of my neck kind of stood up, and I thought, what legislation actually has to say remove gag clauses that prohibit me as an employer the ability to receive my data and use it to act in the best interest of my participants? But unfortunately, we weren't able to get access to our information. And so under the CAA, you now need to remove gag clauses among all of your service providers. This could be your brokers, this could be your carriers, this could be your TPAs, this could be your PBMs. It's removing the gag clauses. Now, most people would say, well, what the heck is a gag clause? So here's a couple of examples of what gag clauses look like. If you open your contract and you see something that says proprietary materials, this is the first part you want to kind of be aware of. Proprietary materials, what does that actually mean? Well, proprietary materials, specifically including any data and information, including any data provided to the plan sponsor in the form of data extracts or otherwise, is not able to be used for price and or quality. And you can't actually provide this information to any of your business associates, so you can't benchmark. This is no longer allowed. And this includes allowed amounts as well. So no longer can be in your contracts. So as you go through your contracts, if you see things that say proprietary materials, you want to really dig into that and say, okay, is this proprietary materials that prohibit me from using my data in order to compare quality and or cost? Here's another example of it. Plan sponsors also specifically agree that carriers have the authority to disapprove of a vendor providing such audit. Again, so allowing your information as an employer to be used and provided to an outside vendor in order to do benchmarking. So these are the types of things that, again, you need to remove. Now, there's a couple of ways of doing this. You could physically go through all of your contracts, and hopefully you catch them all, and you could strike them and say, okay, these are not permitted in my contract any longer. Or you could nullify them by adding additional language to your contract that basically says anything that's not in compliance with the CAA or is prohibited under new regulations is null and void. Our attorneys that we're working with are saying that's the better way to go, because sometimes it's difficult to catch all of the gag clauses. We also have heard that there are some providers that didn't have gag clause language that have now implemented it into their contracts. So that's a little scary when you think about it. So gag clauses have to be removed. The other thing that you need to know about the gag clause removal is that you, as employers, will have to attest that you've removed those gag clauses. And that's going to be happening sometime this year. So you really want to make sure that you understand and have removed all of those gag clauses or nullified it in some way. The second piece is around compensation disclosure requirements. So this is for all of your covered service providers. Now, I think there's some kind of gray area here, because if you read the regulations, it talks about those that provide consulting or broker services to the employer. However, I would tell you that keep in mind, it's really any insurance company, insurance product selection, record keeping, implement and management, and this includes vision and dental. They are considered covered service providers. And they have to disclose to you both direct and indirect compensation. So direct compensation is something you probably are very aware of. You've signed an agreement, you understand that you're paying ABC company $125,000. You may understand that there are commissions or contracted fees or even finder's fees. Back in the day in the retirement space, we actually received finder's fees for placing business with specific providers. It's the indirect compensation that most employers are unaware of. And unfortunately, what we're finding when we go through the indirect compensation is that they were aware about 30% of what they were paying for, and the 70% in this indirect compensation is something that they've never heard of. So I think the last speaker had talked about being bonused by a specific provider for keeping their business with a specific provider or for directing business to a specific provider. That is indirect compensation and now has to be disclosed to you. Any transaction fees, they also have to provide you with a description of all of the services they provide. Now, this is really interesting because one of the things that we're seeing is that some providers are sending out a written description of all the services they provide. That's not what the regulation says. What it says is that all the services they specifically provide to that employer. So be careful of that. And last but not least is the fiduciary status of that covered service provider. Are they a fiduciary in writing or not? How do they need to disclose this information to you? It could be a monetary amount, so it's $125,000. It could be a formula. It could be a per capita charge per enrollee. Trust me, they're going to make it as difficult as possible for you to understand the compensation. When does this information need to be disclosed? It needs to be disclosed in a reasonable time frame in advance of the date in which the contract or arrangement is entered to, extended, or renewed. But employer or ERISA attorneys are telling us no longer than 60 days from the change. So if any contract you've entered into after December 27, 2001, you need new disclosure requirements before you enter into that. And why did the government put this new disclosure requirement into the CAA? Because now you as an employer have to understand who you're paying, what you're paying, and you have to determine if it's considered reasonable under 408B2. Remember, ERISA governs healthcare plans just like they do retirement plans. So a responsible plan fiduciary has to determine if these fees that they're paying are reasonable. Keep in mind, it's not just about cost. It's about the services that you're receiving for the cost that you're paying. And ultimately, I would tell you it's about the outcomes you're receiving as well. What happens if you don't receive these compensation disclosures? Well, they are obligated to provide them. If you don't receive them, you need to ask them in writing. If you still don't receive them, you need to notify the Department of Labor and consider terminating the contract. You also need to deem that they're reasonable, or you could be in violation of prohibited transaction, and the penalties for this could be assessed under IRS. But more importantly, I think the class action lawsuits, again, is most likely what we're going to see happen. Remember, a lot of times the legislation is written, but the courts interpret it. I've given you some language here that we're seeing in the common disclosures that we're coming across. So when an employer gets their disclosure, they're sending it to us and saying, you know, before I attest that I've received this information, I want to make sure that it's compliant. So the first thing that we're seeing is that we, the broker, do not accept any fiduciary or trust responsibilities and are not a trustee or fiduciary. This is very common language that we're seeing. We have not seen any brokers or others really step up to the bar and say that they're acting in a fiduciary capacity. The next common thing we're seeing is that upon request, the broker will provide you with additional information about your compensation that they receive. On request, we will disclose information about what we've earned, including any potential income. This is not compliant. Do not say you've received your disclosure requirements if the language in your disclosure requirement says upon request they will provide you with additional information. That's not what the law says. The law says that they need to provide that information to you, not upon request. So if this language, if you've received your disclosure notices and you go through it and you see, okay, they've listed out the direct, and I understand that, and they've listed out the indirect, and maybe it's been increased slightly, but then there's a lot of language in here that says upon request, it's not compliant. You need to ask them for that information. And the first thing they're going to say is, you know, we're still trying to figure out how we get paid and how that it applies to you. That doesn't fly, unfortunately, because at the end of the day, the buck stops with you as the employer. You need to understand what you're paying it and who you're paying it and if it's reasonable. The last thing that we're seeing is pay to play, the preferred panels of partners that some of the providers use. So the broker may place your insurance or business with members of its panel of insurers or other vendors. And in some instances, insurers or vendors pay an administrative or a management fee to the participants in the panel process. This is allowed. I will tell you that employers should kind of be pushing back on this. How are you being an unbiased party if the preferred panel of partners are paying you additional dollars? But this is some of the language we're seeing, and it is allowed in the disclosure requirements. So, first action of item that you needed to do was to go back and determine, do you have any gag clauses within your contracts that would prohibit you from determining if you're doing what's in the best interest of the participants around cost and quality. The second thing that you want to do is ensure that you've received your disclosure requirements. And if you haven't, that's not necessarily a problem, but you may want to be ahead of it. Remember, if your renewal isn't until January of 2023, you're probably starting your renewal discussions right around now, maybe in a couple of months. That's when you should be receiving the disclosures. And you want to ensure that the language in them is compliant, because again, this is something employers are going to have to attest that they've received it and that is compliant. Also, keep in mind that now that you've received that disclosure, you're going to have to deem it reasonable. So you're going to have to determine the services I'm receiving are tied to X fees, and that's deemed reasonable based upon the market. So you're going to have to do some benchmarking. Benchmarking is kind of the name of the game right now under the CAA. You're going to need to benchmark a lot of things. The next piece of information that we want to talk about is the reporting on the healthcare spend. So this is really around your prescription drugs. So we talked a little bit about hospital costs, which I know that previous speakers talked about, but cost for prescription drugs. So here's a slide that kind of talks a little bit about what the CAA is going to require you to do. The beginning and end dates of the plan year, the number of plan participants and beneficiaries, each state in which the plan is offered, the 50 brand prescription drugs most frequently dispensed, the 50 most costly prescription drugs by annual spend, the 50 prescription drugs with the greatest increase in plan expenditures, information about the total spend on the healthcare services. Now, a lot of employers feel like they're already getting this information and have access to it. So again, if you have a gag clause, you may not have access to it, so you want to make sure that that's removed. But the last three are pieces that we know that most employers don't have access to and are struggling to get. The average monthly premium paid by the employer and the employees, specifically around the prescription drugs, the impact on premiums of rebates, coupons, and any reduction in premiums and out-of-pocket associated with the rebates. So this is something that people have, or employers believe that there is a delay. There's a delay in enforcement on actually reporting on this, but the delay is coming to an end, and you're going to have to report on 2020 plan year, 2021 plan year, and 2022 plan year, and going forward on an annual basis. So I'll go back to the retirement space because I think this is very similar to what we saw. Inside of mutual funds is an expense ratio. And inside of those expense ratios are something called offsets. And those offsets were used to pay record keepers and brokers. And today, those offsets are very clear as to what they are, who they're paying, and in most cases, they're going back to the participants that paid them because they don't need all of the offsets that are being used. This is the same thing that they're trying to figure out in the drug disclosures. So we know that the average drug, costs X, and then there's a lot of people that get paid out of that. There's the wholesalers, there's the manufacturers, there's the pharmacy, there's the PBM. And this is what they're trying to get an understanding of, where all of those pieces and who's paying what, and ultimately if it's in the best interest of the participant. So action item here is agreements with TPAs and PBMs will need to be revised to allow full access to claim information, rebates, fees, and other forms of remediation. So really important. I know a lot of employers feel like they're getting some of this information, but what we're finding is they're not getting it all. And the deadline is coming up soon. So you want to make sure that you have the agreements in place to receive the information that you need in order to meet the new requirements. The last piece is really around mental health and substance abuse benefits and the parity. Now, again, this is something that has been out there for several years. There's always been this parity, but the reality is that the CAA now has allowed us to enforce it and penalize companies for not really reviewing the parity of mental health and substance abuse with their medical benefits. The thing that I think is very difficult is that it's really easy to determine, hey, if I go to a psychiatrist, my copay is the same as if I go to primary care. But it's difficult to quantify the non-qualitative treatments. And this is where we're seeing a lot of employers kind of believe that somebody else is doing it for them. So in 2021, the Department of Labor decided that they were going to go out and audit plans to determine if people were in compliance with the mental health and substance abuse parity, because they felt that if they were compliant with anything under the CAA in 2021, this would be it, because it's been in effect for a while. What they actually reported back was that 100% of the employers that they spoke to and audited were all out of compliance, 100% of them. And most of them believed that their third-party administrator or another party was actually able to provide this information. And what they found is that it's not somebody else providing this information. The employer has to be able to provide it. So if you're relying and outsourcing it to somebody else, that's fine. But make sure that you are able to access that data to be able to provide that information when it is requested. So again, the low-hanging fruit for the Department of Labor, they already knew that 100% of the employers they audited last year are out of compliance in this part, and they believed that this was going to be the easiest thing because they had already had to do some of this. So it's a little scary when you really start to think about it, because the Department of Labor now knows that people are out of compliance and are going to start to kind of enforce and penalize employers that are out of compliance on these key components of the CAA. So I'm sure after this conference, you're all feeling like information overload. My gosh, what do we do next? I feel like I've drank from a fire hose. And what we wanted to try to do was to help you understand that there are, you can no longer kind of be a passive employer when it comes to your healthcare plan, because there are things that could go wrong, just like we saw in retirement with the complacency around the 408(b)(2). We have seen in the market an increased litigation on ERISA in the retirement space, and the settlements are large. In the millions of dollars against employers for excessive fees, for lack of understanding where their offsets are going. Again, think about where your rebates are going. Do you know where all of your rebates have gone, or are you just getting a portion of the rebates? But we're already starting to see the impact of increased litigation in the healthcare space. So there was a school system actually in Florida that believed that they were paying their consultants a capped fee of about $196,000 on an annual basis. And what they actually found when they started to pull, or should I say unravel the onion or pull back the layers of the onion, they found that they had paid the consultant a little over $4 million. So excessive, and again, wide open for litigation. So very important. We know the Department of Labor is actively looking for an employer to make an example out of, to make sure that people understand that they're not playing. The CAA is in full swing. They are looking for the market to react, and that means employers have a new fiduciary responsibility to ask the right questions, to demand the information, and if they're not getting it, they need to notify the Department of Labor and potentially terminate their contract. I'm not as concerned with the Department of Labor as I am with some of the ERISA attorneys that did class action lawsuits in the ERISA space on the 401k and 403b. That's really where I think we're going to start to see a lot of activity. And What we don't want to see happen is the same types of casualties that we saw in the retirement space when the 408B2 regs came to fruition. There was a lot of complacency. Oh, somebody else is doing it for me. Oh, my broker says they've got me covered. At the end of the day, it's your responsibility as an employer to ensure that you're acting in the best interest of the participant and the buck stops with you. So being complacent and kind of being lulled into this environment where somebody else has me covered could be very costly. Just to kind of give you a sense of what some of the attorneys are saying out there is that this is going to have a significant impact in the market. And we definitely saw that in the retirement space. And if you sit on your fiduciary committee in the retirement space, you probably are doing quarterly review meetings. You're assessing if your plan is providing a benefit, if it's at a reasonable cost, the performance of the funds. These are all things you're going to have to do on the healthcare plan. But we know that the impact could be significant on the outcome side. This attorney says that it's more than anything else they've seen since the passing of the ACA, and I know a lot of you remember that. One of the litigators that we're working with says, guess what, guys? Nobody is in compliance yet. So don't feel bad that you weren't aware of this, but now you are. You can't kind of unsee it. Now you actually have to start taking action. And as they said, there's going to be a lot of litigation going forward. So now that you kind of know this, your next question should be, what do I do next? So the first thing that you should do today is to acknowledge that you are a fiduciary under ERISA on your health care plan. Don't assume that somebody else is going to do it for you. Acknowledge, take responsibility, and establish that prudent process. That prudent spending of plan assets. And the best way to kind of establish that prudent process is to establish a fiduciary committee for your healthcare plan. So what does that mean? You might need to set up a charter. You're going to need to determine who's going to be on that fiduciary committee. They should have fiduciary training so that they understand all their duties and responsibilities as fiduciaries. You want to make sure that you understand where the conflicts are. Keep in mind, the marketplace has been riddled with conflicts, and that's been acceptable in the past. Unfortunately, going forward, you need to identify those and determine if that conflict is providing you still the best for your employees. And you really need to document that. The second thing that you need to do, because you are going to be attesting to the removal of gag clauses, is to gather all of your contracts from all of your service providers and make sure that you've done a thorough review. Now, if you have an in-house attorney, great, have them review it. Hire an outside attorney, a ERISA attorney that really understands this. And you want to negotiate the removal of that prohibited language, or you want to add additional language in there that kind of nullifies that gag clause language. And you need to review this on an annual basis because contracts are continuously changing. The next thing that you're going to have to attest to is that you've received the compensation disclosures. And so you want to make sure that you've received that information. Most importantly, you want to make sure that it's compliant because we're seeing a lot of these disclosure requirements that are not compliant. And while we understand that service providers are still kind of struggling with how do we provide this information, they need to at least attempt in good faith to give you the information that is required. And that's what's most important. They should be looking at, what did they receive in 2020? And that gives them a pretty good idea of what they'll receive in 2021. That's a good faith estimate. So that information needs to come forward. When you get that information, you have to benchmark it and determine if the fees and the services you're receiving are reasonable Remember, it could be perceived as a prohibited transaction if you receive that information and don't have any process in place to determine if it's reasonable. Ultimately, if you receive a compensation disclosure that has a whole bunch of services that you've never received, that's unreasonable right there. Or if, you know, the last time you saw one of your service providers was at open enrollment, and yet in their contract it says they're doing all these other things, that's probably not reasonable either. So really important, tie the services to the fees. So those are 2 action items that I would tell you you need to do today. The other thing you need to do is to establish a process in reviewing your contracts with your providers that can help you around the prescription drug reporting, as well as the mental health parity. Really important. Do not assume that the vendors have this information, that they can provide it to you readily. You are the fiduciary. The buck stops with you. The DOL does not have authority to go after these providers. They do have authority to go after the plan sponsors. Now, that's not to say that if litigation happens that these plan sponsors aren't going to provide or aren't going to pull some of these providers in. But again, keep in mind, at the end of the day, the big F is you, fiduciary. So those are the couple of things that we wanted to hit on today. I have provided you with, and I'm going to stop sharing my screen and just pull up a couple of things that we've provided everybody with that we're going to go through. Hold on one second here. Stop sharing my screen and just grab another piece of information. Okay, can you see my screen? Hopefully you can. I can't hear anybody, so I apologize. But we provided you with some handouts. So the first thing that we provided you with is a quick pop quiz. I know I'm probably stopping you from getting to lunch, and some of you may be thinking more about lunch than the information that was provided. But let me ask you, who's responsible for collecting and maintaining all plan documents, reports, and filings? Is it the broker of record? Is it the TPA, or is it the health plan fiduciary committee? Hopefully all of you circled B. Yes, it is the health plan fiduciary committee. You are responsible for that. What amount of direct or indirect annual compensation identifies a plan vendor as a covered service provider under the CAA? Now, we didn't talk about this actually, so I apologize. It was on this slide. But anybody that receives direct or indirect compensation over $1,000, it needs to disclose that information to you. So again, it's that C, over $1,000. What type of contract clause, now prohibited, restricts a plan sponsor access or use of plan data? Remember, this is your data. So hopefully as you go through this, you know that it's the Gag clause, it's C. And then what law extends ERISA compensation disclosure requirements to the health plan service providers in order to address unreasonable industry compensation practices? You would be right, it's the Consolidated Appropriations Act. So again, just giving you some pop quizzes to make sure that you paid attention. We've also provided you with additional information to do a self-assessment. So this is really a self-risk assessment. Has your organization established a health plan fiduciary committee? Yes or no? Has your organization adopted a charter? Remember, if you establish the committee, you want to establish a charter to determine what that committee can and can't do unless it seeks authority at a board level or others. Has your organization established a separate HIPAA compliant filing system to store data claims? This is your data, you need access to it. You're going to need to be able to provide reports upon request. You want to make sure that you're able to store that data so that if you change carriers or TPAs, that data remains with the plan. So when we look at covered service providers, compensation and benchmarking, have you received that detailed disclosure from your covered service providers? Do you understand the direct and indirect compensation? Is the language appropriate and compliant? Have you reviewed their disclosures to ensure that they're compliant, or have you asked for them to be updated? So we had a lot of employers that received, asked for the disclosure requirements and they got last year's. And last year's doesn't need to be compliant because it wasn't in effect for any contract that was signed or from a covered service provider after December 27, 2021. So are you aware of the potential conflicts of interest that may exist between your covered service providers in the plan? And have you had your covered service providers disclose their conflicts, perhaps attest to their conflicts? Removal of prohibited transaction. Have you reviewed your contracts? If not, add a point. Are you prepared to attest that you've removed your gag clauses? Again, if you haven't reviewed them, this is, and I'll tell you, I think this is going to be one thing that comes to fruition if there is litigation. They're going to say, when did you remove your gag clauses? If you haven't removed your gag clauses, then ultimately how as an employer have you been able to act in the best interest of the participant if you really didn't have access to your information? Fiduciary status, make sure you understand who is a fiduciary. If they're a fiduciary in writing, collect that information from them. Keep in mind that in the retirement space, there are the ability for providers to be co-fiduciaries on plans. In the healthcare space, we haven't seen a lot of that yet. We're starting to. We actually are in the process of adding that service where we can become a co-fiduciary in a plan and sit on the same side of the table as the employer as a true advocate. When you talk about the reporting services, have you established which service providers are going to be able to provide that information? Is it your TPA? Is it your PBM? Is it a combination of them both? Have you established which service providers will complete your mental health parity analysis? Make sure that they can provide all of the information that's going to be required, both quantitative and non-quantitative. Really important. Have you benchmarked your plan design in the last 3 years? Are you looking at proactive ways of controlling costs and enhancing benefits? Have you benchmarked your prescription drugs within the last 3 years? And so these are pieces, and the other last little thing is, when was the last time you audited your paid claims for accuracy? Really important. This is prudent spending of plan assets. So you need to make sure that the dollars that you're spending are actually being paid to the right parties and are accurate. We see a lot of that where if you're not auditing your claims, you perhaps are paying for something that you're not actually receiving. We had one employer that started an audit of their claims, and they found that a gentleman that actually went in to have his toe amputated, the claims actually showed that he had his leg amputated. Totally incorrect. Had his leg amputated on the right and his foot amputated on the left. Wrong. So obviously that claims shouldn't have been paid. So these are the things that you need to start to assess. So hopefully this gives you kind of some type of guidelines or some actionable ideas to start you on the process. This is an undertaking that you're going to need the right partners, the partners that are going to be transparent through the process. And again, it doesn't come down to just cost. It comes down to the services you're receiving and, most important, the outcomes that you're receiving. So again, if we look at quality of care that you're getting, are your employees going to the appropriate providers for the right cost and receiving the right care? Those are all things as plan sponsors you want to be able to acknowledge, determine, and now document going forward. So I'm going to stop sharing my screen and see if we have any questions.
So my question to you, or a question that I would like to pose to you, we think we need more training here. That is the reason I'm actually, for the past 2 months, I've been doing 2 hours a week training. And I'm actually, the Alliance is sending me to the Center for Board Certification to start my certification process. It truly is daunting. So if we want more training as a marketplace, as a group of employers, please let us know, because we wanna train, we wanna do more of this, but only if it's useful to you all, right? Because it is, we are the fiduciaries of your dollars as well, so we need to be very prudent. This is, just the geek in me is completely out, and I'm totally excited with this work, and I'm bouncing every time that I have these classes that I'm taking, but really incredible work. I would like to ask our President and CEO, Cheryl DeMars, to come back to the stage before she dismisses us for lunch. We have a couple more items to take care of. So thank you, Jamie, if you can hear us. Thank you so very much. This was absolutely amazing.
Yes, so just a few quick things. I just want to make mention of one thing. As Melina said, this may sound daunting. I want Alliance members in the audience to know you don't have to worry about the gag clause part in your provider contracts that we hold on your behalf. We don't have gag clauses. There might be a few remnants in our contracts from long ago that have a gag clause in, but we've superseded that with the language that that Jamie talked about before, that if there are laws that, supersede, that this is null. You can tell I'm not the contract writer, but I just want to at least give you that reassurance that your provider contracts are in good shape from that perspective. So we are wrapping up, and before I get to the closing part, I just want to take a moment to recognize Paul Meyer. Paul, are you here? And would you stand, please? I don't care if you are embarrassed. I know you are. Yes, so Paul Meyer. You don't have to come up. Paul, oh good. Paul is our Chief Operating Officer and also serves as the board treasurer for the treasurer of the board. And Paul has been with the Alliance for 25 plus years. He's retiring on June 1st. And so this will be his last event as an Alliance employee. You can always come back as a guest. But Paul, I just want to thank you so much for all of the years of service to the Alliance. You have been such a fabulous mentor, friend, colleague, leader, and importantly, good steward of our members' resources. And we just wish you the very best.
Thank you. Can I say something? Thank you very much. It's been an honor, absolutely. I said to Cheryl during one of the breaks, I said, stuff like this gets me all jacked up, and I might retract my retirement. I feel that way today. I have a feeling tomorrow I might feel differently. But this is really good stuff. This is a really good program, really important work. I feel like we're right on the cusp of really making some needed and important in doing that kind of work, not only in Madison, but across this country. So way to go, Alliance. Let's keep up the good work. Thank you.
Thanks, Paul. So it's also my privilege to welcome Doug Benzine as our new Vice President of Finance and Operations. Doug, would you stand, please, so people know who you are? Doug is in week 4. This is the start of week 4 for Doug, and Doug comes to us with a great background, having held senior level positions in finance and operations, in health insurance, as well as for the CUNA, our Credit Union National Association, who, like the Alliance, is structured as a cooperative. So we're, Doug, delighted to have you as part of our team, and can't wait to see what you'll help us do. So now just the routine stuff, CE credits. If you're claiming continuing education credit for SHRM or HCRI, be sure to visit the registration desk on your way out to sign out. There's also a handout available at the registration with specific instructions on how to claim your SHRM credits. And lastly, mark your calendars for our next 2 events. On June 8th, we're having a webinar on the obesity epidemic in partnership with the Wisconsin Collaborative on Healthcare Quality. And on October 25th, we'll have our fall symposium and annual business meeting. So we look forward to seeing you there. And those of you who are joining us by webinar, we hope that you'll be able to come live in October when we're back here at Monona Terrace. So thank you everyone for joining us today. It's been great to see you, and we're gonna lunch is served at the back of the room. We invite you to grab your lunch and come back and mingle with the rest of the people that are here in the room. It's one of the things that we know people enjoy the most about these events is the opportunity to network and compare notes with one another. And we certainly have heard enough today for good grist for the conversation mill. So thank you all. Enjoy the rest of your day.